All right, hello everyone. Today we are going to tackle chapter 19, which is the respiratory system. All right, here are some roots, prefixes, and suffixes that you will need to know. Some of them you might be familiar with. Alveole, alveoli, you might have heard. That's where gas exchange occurs. A bronchus, bronchioles, your bronchi, like your windpipe, your trachea, bronchus. We have a right and a left bronchus. Carcinogen. Carcin is a spreading spore. Um, let's see, cricoid cartilage. Uh, Epi means upon, in this case, epiglottis. Exhalation, means to breathe out. Heme means blood. In this case, we'll be talking about hemoglobin. Inhale means to breathe in. Phren means diaphragm. We talked briefly about the phrenic nerve before. All right, so what does the respiratory system do? What is the respiratory system? So, we know that the respiratory system breathes in, brings oxygen into the body, and expels carbon dioxide. We breathe in oxygen and we breathe out carbon dioxide. But it also, it's a passageway that when we breathe in that oxygen, especially on like a cold day, it's going to filter that air that we breathe in, and it's going to moisten that air and warms that incoming air, so that the air that we breathe in, if you're in northern part of Canada or Maine in the middle of winter, if it's negative 20 degrees outside, that air that hits your lungs isn't negative 20 degrees. It's going to be warmed somewhat, a lot, so that the air doesn't hit your lungs at negative 20 degrees. So it's going to warm the air and transport it to the lungs and eventually to the body. After it passes through these microscopic air sacs called the alveoli, where gas exchange happens. Also, it produces these vocal sounds that allows you to speak and sing and talk and mumble and tell your older brother to go to where, and helps with your sense of smell. We talked about the sense of smell, in chapter 12, and we have those mucous membranes in our nasal cavity, and the purpose of the mucus is to dissolve the odorants to allow that cranial nerve number one, the olfactory nerve, to provide that sense of smell for you. And it also helps regulate the blood pH. So a lot of times people don't associate the respiratory system with the cardiovascular system and regulating the blood pH. So we'll spend a lot of time talking about regulating blood pH. All right, so respiration itself. So respiration is how we perform that gas exchange. We have this, the air that we breathe in, that air in the atmosphere, and how do we get that air from that atmosphere into our body, and then from our body to the cellular level, and all those chemical reactions that provide the cell with the energy to function. And obviously we know that oxygen is required for organisms to live, but oxygen is required for cellular respiration. Remember that for cellular respiration, we use glucose and oxygen on the anaerobic side, or on the aerobic side, citric acid cycle, to produce those ATPs, NADHs, FADH2s, and we produce the end products, or the waste products, are carbon dioxide, water, and ATP. So when we look at respiration, we have kind of three main components, and we can break down those three main components into different components. But we have external respiration, which is the act of taking air out of this world that we live in and bringing it into our lungs. And performing that gas exchange at the alveolar level. And then we do that gas exchange, and then we transport the gas that we breathe in, and we exchange it with the body cells, or we exchange it at the cellular level, and that's called internal respiration. And then when the cells use that oxygen to produce carbon dioxide, water, and ATP, that's called cellular respiration. So external respiration we can break down into two different components. We have ventilation, which is just the act of moving air into our lungs. So the act of inhaling and exhaling is ventilation. Perfusion is the actual gas exchange itself. So perfusion is taking the oxygen from our lungs and putting it in our bloodstream, and taking the carbon dioxide from our bloodstream and putting it into our lungs. So perfusion is the gas exchange itself, and ventilation is the air movement from the atmosphere into our lungs, or from the lungs into our atmosphere. And make sure that you know the difference between the two, because ventilation doesn't necessarily mean that you are perfusing. You can be breathing fine, you could be ventilating fine, but that doesn't necessarily mean that you are perfusing fine. You might be able to breathe in and out. You might be able to have no problems breathing, moving air in and out of your lungs, but that doesn't necessarily translate into you actually getting oxygen into your bloodstream and carbon dioxide out of your bloodstream. So think of conditions like emphysema or COPD, or let's say you have pneumonia, or you have increased mucus production at the alveolar level. You might have no problem breathing, but that gas exchange is impaired, leading to altered perfusion. So there's a big difference between ventilation and perfusion. And we know for cellular respiration that we produce ATP, and that happens in the mitochondria for aerobic respiration. Anaerobic respiration, glycolysis, occurs in the mitochondria, or in the cytoplasm of the cell. And for aerobic respiration, citric acid cycle, we're going to take that oxygen, aerobic respiration, and we are going to create those ATPs along with the NADHs and the FADH2s, and use the electron transport chain and convert those NADHs into, each NADH goes to 3 ATPs, and each FADH2s go to 2 ATPs in the electron transport chain. And this whole process, the cellular respiration process, the end products are, like I said many times before, carbon dioxide, water, and ATP. And hopefully we're going to breathe out that carbon dioxide. All right, so the respiratory system, we can divide the respiratory system into an upper respiratory tract and a lower respiratory tract. The upper respiratory tract is the nose, nasal cavity, sinuses, pharynx, and larynx. It is not the pharynx, and it's not the larynx. Pharynx and larynx. Lower respiratory tract is the lungs, trachea, bronchial tree, and alveoli. And I will say, if you look at the picture, if you kind of take away the lungs and just look at the trachea, the bronchial tree, and kind of turn it upside down, it kind of looks like an upside down tree that kind of has no leaves on it. All right. So the nose itself, it's part of the upper airway system. We have these things called nostrils. Those are, we also call them nares or external nares. Some people say nares. And those are just the openings that allow us to breathe. You know, we can breathe through our nose, we can breathe through our mouth. But if we breathe through our nose, the air is going to pass through our nostrils or our external nares. And then right inside of our nose, we have hairs, nasal hairs that are going to help filter out any dust that we might breathe in, and hopefully collect that dust. And we can either, blow our nose and get rid of that dust. And so that nasal cavity, it's just a hollow space that's right behind our nose. We have a left and right portion of our nasal cavity, and it's separated by your nasal septum. And it's that nasal septum. Some people break your nasal septum, and you might have to have surgery or a nose job, but most of the time you'll just put a little device on there and call it a day. And we have these things called nasal concha, these turbinate bones that kind of curl up under, they curl in on themselves in these lateral cavities, lateral walls of this cavity, this nasal cavity. And they form these little passageways called a meatus. Meatus is single, meatuses are plural. And they're also going to help with the olfactory sense, your sense of smell. And you can see we have a superior, superior, middle, and inferior nasal concha there. We talked a lot about the nasal concha in chapter 12, I believe, and we talked about it in lab as well. So functions of the nasal cavity. The nasal cavity itself is lined with this mucous membrane. It's a pseudostratified ciliated epithelium. So remember, pseudostratified, it's one layer, but it appears multi-layered. So the nuclei are at different levels, giving it a multi-leveled or a multi-layered appearance, but it's only one layered. And it has these cilia on them, so they're going to be these hair-like projections. And epithelium. And they have these goblet cells. And remember, goblet cells produce mucus. And the purpose of this is to trap dust and pathogens or whatever harmful things that come into our body. So we have our nasal hairs, our nose hairs that are going to trap dust and pathogens. And now we have our nasal cavity with these mucus cells, these goblet cells that are also going to trap dust and pathogens. So, and we'll see this, cycle continue down through our respiratory, the anatomical side of the respiratory system, that a lot of the function is to trap dust and pathogens, because we don't want dust and we don't want specifically pathogens to enter our body. Remember, I don't even remember what chapter it was, the lymphatic chapter. We talked about the mechanical barriers, our first line of defense for immunity. These are mechanical barriers. So we also have these cilia. Remember, pseudostratified ciliated epithelium. These cilia are going to kind of move and sweep this mucus towards the pharynx, the back of the throat, where most of the time you're just going to swallow this mucus, and the pathogens and these dust particles, if there's any living material, but the pathogens are going to be destroyed in the stomach because the stomach acid is 1.5. The pH is 1.5, pH of 2, pH of 3. So these pathogens are going to be destroyed by the stomach acid, which is going to prevent any infection, because remember, a lot of pathogens are protein based, and proteins like to live in a very narrow pH range, pH of like 6 to 7. And if you introduce them into your stomach acid, which has a pH of 1.5, 2 to 3, it's going to destroy those pathogens. So we have another barrier for preventing infection. We talked with the we've already talked about one of the functions about conduction of air, and how that it moistens air, it warms the air, and it filters the incoming air, and that it traps those small dust particles or those pathogens. We talked about the nasal concha, those little three, the superior, middle, and inferior nasal concha, that are going to kind of fold in on itself. But it also helps, it'll increase that surface area, one, for your olfactory sense, but two, to help with this whole mechanical barrier process to kind of get rid of any bad gunk that you smell in or that you breathe in. So here you can see the pseudo-stratified appearance, and that there's that the nuclei are at different levels, but each cell does come in contact with the basement membrane. So we really only have one layer of cells. So it is a pseudo-stratified. You can see the cilia on top here. You can see the goblet cells here. Remember, goblet cells produce mucus. So you can see the kind of the drawing, and then over here you can see the histology slide, the cilia on top, with the goblet cells and the pseudostratified ciliated epithelium. All right, moving on. So we also have sinuses. You get a sinus headache or you get a sinus infection. Basically, sinuses are just air-filled pockets, air-filled spaces. We have four different sinuses. We have a frontal sinus, a maxillary sinus, an ethmoid sinus, and a sphenoid sinus. You're going to have to know where these are anatomically. So your frontal sinus, is where your frontal bone is. Your ethmoid sinus is kind of in between your eyes. Your maxillary sinus is where is on the sides of your nose, right next to your nares. And your ethmoid sinus is going to be or your sphenoid sinus is going to be right in front of your ears. And actually, if you take a flashlight and kind of hold it underneath your eyebrow, sometimes in like a really dark room, and if you hold it in front of a mirror, you could actually can kind of light up your frontal sinus. So, if you're not doing anything at 2:00 in the morning, go try this in front of the mirror, but, don't say Candyman 5 times, because some bad things might happen. Anyway, if you ever saw that movie, you know what I'm talking about. All right, so these sinus things, they're going to open up into the nasal cavity, and your sinus is also called a paranasal sinus. They have these they're mucous membranes. And because they are filled with air, they're going to reduce the weight of the skull, and they help resonate your voice. And singers are actually trained to kind of use your sinuses to help with your airflow to create what I call a singer's voice. And we know that you can have sinusitis, or that you can get an infection of one of your sinus areas. And it's usually due to an allergic reaction or an infection that can block one of your sinuses. And that will prevent drainage, and that's why you feel the pressure build up in one of your sinuses. That's why you have that sinus pressure, or a sinus headache. All right, smoking. The effects of smoking on the respiratory system. We know smoking is bad. This goes smoking, vaping, and also marijuana as well. So you don't see the effects of smoking, today, tomorrow. You're going to see the effects years from now. It's a very slow, progressive disease. It's a slow, progressive onset of the effects of smoking. And we know that people do die from lung cancer. But what smoking will do is that cilia that's, inside of our nasal cavity and inside of our respiratory passages, those cilia will eventually slow down the motility or the movement of those cilia, and it will eventually paralyze those cilia, and it will eventually decrease the number of cilia present, so that the cilia are essentially non-functional or non-existent. So you remember the cilia is there to collect those dirt, that dust, particles, and those debris and those bacteria, and kind of expel that bacteria out in mucus so that you can swallow it, or so that you can cough it up. And because smoking kind of makes that cilia non-functional or non-existent, those dirt and pathogens can no longer be removed from the respiratory system. And so now since we don't have that protective mechanism anymore, that cilia, you're inhaling the dust and you're inhaling the pathogens that can now enter into your body. And then we have the smoker's cough, which I'm sure you're all familiar with. You've all heard it. And that's because we don't have that cilia there anymore, and we have that excess mucus production. And the cilia is not there to move that mucus up, so smokers have to cough up the mucus that the cilia would otherwise kind of bring up on its own. We already said, pathogens can now access the respiratory surfaces, causing more infections. And it says chronic coughing leads to chronic bronchitis. So what that means is, what typically would happen is those bacteria would essentially be stopped either in the nasal cavity, or as the bacteria would be inhaled into the upper parts of the respiratory system. But because of smoking, that cilia, like I said, is either non-existent or non-functional. So now we're breathing that cilia all the way down into the lower, or we're breathing those pathogens all the way down into the base of our lungs. So the pathogens have more exposure into in our lungs or into our respiratory passages, and now we are coughing. So now we're bringing those pathogens back up through our respiratory system, and coughing, that mucus. Remember, anytime mucus or anything comes in contact with a tissue, cells rub off. Cells rub off. You swallow food, and that food bolus is going to rub off some cells in your esophagus. So when you cough, that mucus is going to rub off some cells in your respiratory tract. So now when you cough up that mucus, the mucus is rubbing off cells, and now that bacteria that should not be there now can easily or more easily enter into your bloodstream through your respiratory system. Because that mucus is now kind of tearing away at that epithelial layer. All right, and also we'll find with smoking that bronchial thickening results in difficulty with expiration. So we haven't talked about, where the trachea is yet, or where what parts of the bronchial tree are what yet. But the trachea is your windpipe, and then it'll separate in the right and left bronchus, and then it'll divide even more. But with smoking, you're going to have a problem with expiration, with exhaling, with breathing out, because that bronchial tree or that right and left bronchus will thicken a little bit. You don't have a problem typically with inspiration. You'll have a problem with expiration or breathing out. The alveolar walls, so your walls of the alveoli are going to be destroyed, leading to emphysema. And we'll talk a little bit about emphysema and how those alveolar walls are destroyed a little bit later on. But basically, the alveolar walls are basically going to lose their elasticity. Think of like the alveolar walls or the alveoli as like a clump of grapes. And if you take 50% of the grapes away, that's kind of like what's going to happen with emphysema or with smoking. Abnormal cells start dividing and replacing these ciliated cells. Remember, those cilia are going to start to become non-functional or non-existent. Lung cancer develops in 20% of smokers. So it says these abnormal cells may start dividing to kind of progress to cancer. And it's going to be a change in the epithelial cells that lead to development of lung cancer. We'll see in the respiratory system that we have these things called type 1 cells and type 2 cells. And we'll see that that is basically these type 1 cells, these epithelial cells that are going to change. These abnormal cells may start dividing. They're going to be the epithelial cells that are going to be the ones changing. And we do know that secondhand smoke or environmental tobacco smoke endangers non-smokers as well. It can actually, firsthand smoke or secondhand smoke can increase your risk of developing lung disease and or heart disease. So here you can see a picture of normal lung tissue, and here you can see a lung tumor. This is actually a cancerous lung. When we do lab, we'll see we'll have some healthy lungs that we'll look at, and we'll look at some diseased lungs as well. All right, so the pharynx. The pharynx is this space that is posterior or behind the nasal cavity, your oral cavity, and your larynx. And it is just a passageway for food and air. So you can see here that the pharynx can be divided into 3 sections: the nasopharynx, the oropharynx, and the hypopharynx, if we're going from superior to inferior. So here you can see the nasopharynx, the oropharynx, and the hypopharynx. And it's a passageway for food and air. The nasopharynx is just going to be for air only, but the oropharynx and the oropharynx is going to be for food and for air, and the hypopharynx is going to be for food and for air. So you're going to have to know the three portions from superior to inferior, inferior to superior. All right, so the nasopharynx it says is superior to the soft palate. Remember when we talked about the mouth, we have the hard palate here. That's the hard thing that's right behind your teeth. And then we have the soft palate that's behind that with the little hanging down thing called the uvula. And the nasopharynx also has these where your auditory tubes open up into. Remember, your auditory tubes drain into the back of your throat or your nasopharynx. Your oropharynx is just really posterior to your mouth. And your laryngopharynx is kind of inferior to your oropharynx. So hypopharynx or laryngopharynx, either one is going to be fine. I think this textbook calls it laryngopharynx, but some people will call it the hypopharynx. Just know that either one is fine. But I think for testing purposes, memorize it as the laryngopharynx. All right, and in the larynx, so here you can see, the larynx here. The larynx is above or superior to the trachea, and it's anterior and slightly inferior to the laryngopharynx. So it's just anterior, which means in front of, and slightly inferior to the laryngopharynx. So we can see that. And it's superior or above the trachea. So we can see that. And it's a passageway for air only. So food should not go down the trachea. We do know that it does sometimes, but it should not. So it's a passageway. The larynx is a passageway for air only. And it's going to move air in and out of the trachea. This is where our vocal cords are housed. It has a lot of muscle and cartilage tissue. It's bound by this elastic tissue. This is where we are going to find our hyoid bone. Remember, the hyoid bone is the only bone that does not articulate with another bone. And this is the bone, if it's broken, there's a high probability that you were either strangled or hung if you were found dead and your hyoid bone is broken. All right, so with the larynx, we have three kind of bigger cartilages that are single cartilage. We have this thing called a thyroid cartilage. Some people call it the Adam's apple. So here you can see your thyroid cartilage. It's the largest cartilage. It covers your thyroid gland. We also have a cricoid cartilage, which is just below your thyroid cartilage. And it's an unpaired cartilage. And then we also have this epiglottic cartilage, which is on the posterior side of the larynx, and it's the central portion of your epiglottis. Your epiglottis is going to be what closes off. It's what closes off food and whatever you drink from entering the trachea. So when you swallow food, this epiglottis is going to cover up the trachea. So that's just the purpose of That's the purpose of the epiglottis, is to cover up the trachea when you swallow food or beverages. And then we also have these three smaller pairs of cartilage. So remember these, we have single cartilages and pairs of cartilages. We have the arytenoid, corniculate, and cuneiform cartilages. And basically those are going to be there for to help with your vocal cords tension and for speech. And then it will also close your larynx for when you swallow. All right, so looking at the larynx more kind of close up, we're going to see that it has these two pairs of horizontal vocal folds that have muscle and connective tissue. We have these we call them false vocal cords. You can kind of see those right here. Those are false vocal cords. We also call them upper folds or vestibular folds. They actually don't produce any sound. They're not involved in sound production at all. All they really do is just kind of close off the airway when we swallow. And then we have our true vocal cords. They are also called the lower folds. Here you can see the true vocal cords. And that's what helps us produce our sound. And when we produce the sound, we can kind of alter our vocal cords, and we can change the shape of our vocal cords to produce, different pitches. We can talk really high, we can talk really low. So if we want to produce higher notes, if you want to sing in a higher octave, or if you want to talk in a higher tone of voice, you would just increase the tension on your vocal cords. And if you want to increase the volume or increase the sound or increase the intensity of your voice, you can change the force of air passing over your vocal cords, which would cause the vocal cords to vibrate, and that's how we produce sound. So your vocal cords vibrating is how sound is produced. And then we have this structure called the glottis, and basically the glottis is your vocal cords plus the space that is between them. And I really like this picture right here, only because this is what I see a lot. I work as a as a nurse anesthetist, and so oftentimes, a lot of times, we intubate our patients. We put a breathing tube into our patients to help them breathe while they're going through surgery. And we have this little, excuse me, we put in this device to kind of open up the airway so that we can see what we need to see in order to stick the breathing tube down. And this device kind of would rest right here, and then we would pull up on this device that would allow us to see this structure. And this is actually a really good view. And I would put the breathing tube, the endotracheal tube, kind of right through there in that hole into the trachea. And I would know that the trachea has passed through the vocal cords, which are right here. And then I would have a successful intubation. Now, with laryngitis, which seems to be what I'm almost suffering from, laryngitis occurs when the larynx becomes irritated and or inflamed from an infection. It could be a bacterial infection, or it could be from acid reflux, or if you have overused the vocal cords. If you have strenuous use of the vocal cords, that could be a cause of laryngitis. So infection, acid reflux or strenuous use of the vocal cords. And most people with laryngitis, they either lose their voice or they have a quiet, raspy sounding voice. All right, moving on to the trachea. Most people call it the windpipe, but now because we are experts in anatomy, we can call this the trachea. Trachea is basically a flexible cylindrical tube. It's about 12.5 centimeters in length and about 2.5 centimeters in diameter, and it extends downward and into the and it'll branch off into the right and left bronchus. And it sits in front of the esophagus. So if I palpate right here, I'm actually palpating my trachea. And then if I like put my fingers, which, don't do it, but, you really can't feel your esophagus. But if you rip out your trachea, then you'd be able to feel your esophagus. And the trachea is lined with the ciliated mucous membrane that we've talked about before, and it has that same pseudostratified ciliated epithelium that we talked about before. However, it's the columnar epithelium. Up, I guess I should say up here, lined mucous membrane, pseudostratified ciliated epithelium. I guess I should say columnar epithelium as well. All right. My bad. All right, so let's get back to this. All right, so the trachea, and it also has the goblet cells. Remember, goblet cells secrete mucus because we do have gunk that, the nasal cavity doesn't always pick up all of that dust and the debris and the pathogens. So we're still going to have mucus secreting cells, the goblet cells, in our trachea. And when we look at the trachea, it's going to have about 20 or so C-shaped rings of hyaline cartilage. And the C-shaped rings, they're C's, they're not O's, so they don't go all the way around the trachea, but they're C-shaped, so they don't close in the back. And basically that'll help keep the trachea opened up. And as the trachea goes kind of downward, it's going to branch off into the right and left bronchus or the right and left bronchi. We can say we have a primary bronchi, a right primary bronchi, and a right primary bronchus, and a left primary bronchus, or a right and left primary bronchi if we're talking about plural. And there is a procedure called a tracheostomy where we could actually put a breathing tube, typically we do the breathing tube in the mouth for, a surgery, but, we don't want, this isn't, a breathing tube in the mouth is not for long-term use. It's, once we get to the 10-day mark, we want to kind of start thinking about, long-term intubation. Do we want to go to a tracheostomy? And which is basically going to be a hole that's about right here. We would create a hole into the trachea, and we would kind of put in a little tube about, that long that would kind of go into the trachea, and we would hook up the ventilator right here. And it would actually help with bacterial transmission and stuff like that. Also, you could do that in, you could do a tracheostomy for, an emergency procedure. Let's say someone loses, someone loses their airway and you can't get someone intubated orally, and you have to do a cricothyroidotomy, and which you don't want to go down that route because that's just a mess. But a tracheostomy is is where you would go in and you would kind of cut. You would cut right here. All right, so you can see like right here is where you would cut. You make your incision for a tracheostomy. Another reason why you would do a tracheostomy is, let's say the patient was involved in a car accident and they have a bunch of facial fractures, and you can't manipulate the face to, insert the little device to get your airway view. Let's say their face is too broken to get a good clear view of the airway. All right. Your bronchial tree. So remember that the trachea branches off into your right and left primary bronchus. And remember that how it looks like an upside down tree. So we have our right and left primary bronchus. Your right primary bronchus is going to go into your right lung, and your left primary bronchus is ironically going to go into your left lung. And then from there, we're going to just continue to divide and divide and divide and divide. We're going to go into these lobar bronchi, then segmental bronchi, interlobular bronchioles, terminal bronchioles, and then we have these respiratory bronchioles, alveolar ducts, alveolar sacs, and then finally down to the alveoli themselves. So, and you can see, you're not going to have to memorize the numbers, but these lobar bronchi, and then the segmental or tertiary bronchi, these interlobar bronchioles are going to enter the lobules of the lungs, and these terminal bronchioles, we have about 40 to 80 in each lobule. All right, so now from here on down, we have these respiratory bronchioles, and this is where gas exchange starts to happen. Obviously, we've always said, gas exchange occurs at the alveolar level. Yes, that is true. However, once we get to the respiratory bronchioles, gas exchange can start there. It's just most efficient. Gas exchange is most efficient at the alveolar level. But gas exchange can start to occur at the respiratory bronchial level. And then as the respiratory bronchioles start to divide even more, they divide in the alveolar ducts, and then the alveolar sacs and the alveoli themselves. So here we can see we have, you can kind of see the trachea, which are going to go into the right and left main bronchus. And then you can kind of see your segmentals. Those are going to be some segmentals. And then you can see more branches. You can kind of see even more branches. And then we can't really go down microscopically on this picture, but you can just see how everything divides and divides and divides and divides and divides. And then, so eventually, so if we go back up here, we have these interlobular bronchioles. So here, this is where we're going to start. We have interlobular bronchioles, which have these smooth muscle that's kind of wrapped around them. And then they are going to divide into these terminal bronchioles. So here we would have these terminal bronchioles, and then they branch off into these respiratory bronchioles. And that's where I said those are the first structures to conduct gas exchange. So here, this is where gas exchange could first happen. Is it efficient? No, but it can happen. So we have these respiratory bronchioles here. Respiratory bronchioles are here. And then alveolar ducts, sacs, and alveoli. So here you can see the alveolar ducts, and then you can see the alveolar sacs, and the individual alveolus is singular, or alveoli is plural. And gas exchange is going to be most efficient at the alveoli or alveolar level. And you can see how there's, there's a bunch of capillaries wrapped around each of the alveolar sacs. And I said, remember earlier on, I said, think of like the alveolar sacs as a bunch of, grapes that are hanging down. So you can see that, these sacs of grapes, or the alveolar sacs, look like a bunch of grapes, and all of these membranes are kind of connected. And that increases that surface area for gas exchange to happen. And when I use the grape analogy, we were talking about emphysema, and I said, think about, taking that bunch of grapes and just kind of plucking out 50% of the grapes. So if I got rid of this alveolus, this alveolus, this alveolus, this alveolus, this alveolus, and this alveolus, we reduce that surface area. So now we would have one bigger alveoli there. We would have one alveolus there. So the surface area would decrease dramatically when, like cases like emphysema, when the alveoli would kind of disappear, and that surface area would become decreased. All right, so this is like how the bronchial tree looks without lungs. Remember I said, if you turn it upside down, it looks like a tree. All right, this is at the cellular level of the alveoli. You can see that it is a simple layer. It has one layer, and that's beneficial for gas exchange, because we would rather have gas exchange happening at a one layer level as opposed to a gas exchange happening at something that crosses 187 layers. So here you can see these. So there's your bronchiole, and there's an alveolus there. Here you can see some capillaries here. You can see alveoli, an alveolus there, alveolus, alveolus, alveolus. All right. Structures of the respiratory tubes. So we talked about the trachea, and that they have those C-shaped rings. But as the trachea branches off into kind of the smaller structures, the structures themselves are going to contain less and less material. So instead of the C-shaped rings that we saw with trachea, we're going to have these cartilaginous plates in the respiratory tubes. And then as your bronchi continue to branch, remember we had that in the trachea. In the trachea, we had the pseudostratified ciliated columnar epithelial cells, and as we go from the trachea to the bronchi to the bronchioles down more towards the alveolar level, the tissue is, or the cellular layers are going to become narrower, the amount of cartilage is going to decrease, and that epithelial lining is going to become thinner. And eventually your cartilage is going to disappears in the bronchioles, and that's going to allow for diameter changes. Remember, cartilage is there in the trachea to keep the trachea opened up. And without cartilage, now that structure can open and close, and that's going to allow for bronchodilation and bronchoconstriction. And we'll see, there's different hormones that will allow for bronchodilation and bronchoconstriction. We have different medications that will allow for bronchodilation, bronchoconstriction. You take an asthma medication that will typically allow bronchodilation. In asthmatics, you encounter, this allergen, usually maybe like an allergic, you go outside and you breathe pollen and you start to have this wheezing and you use your inhaler to open up your lungs a little bit. That's bronchodilation. And then your smooth muscle, remember that smooth muscle is around your, the trachea and the bronchial level. That's going to become more prominent, but then it's going to diminish as we get to the bronchioles and the alveolar ducts. And then at that point, it's going to disappear. So you can see here, once we get down to where gas exchange occurs in the respiratory bronchioles, we don't have smooth muscle. And then I said here, the epithelial lining becomes thinner. So actually what I'm going to do, as the respiratory tubes become thinner, your epithelial lining changes. So what I'm going to do, is we're going to move this up here. So with your pseudostratified, let me just erase this. All right, so with we remember that in the trachea, we're gonna have that pseudostratified ciliated columnar epithelium, and then also once we get down to the bronchial or the primary, the left and right primary bronchi, we're gonna have pseudostratified ciliated columnar epithelium. But once we get down to the respiratory bronchial level, so once we get down to here, we're going to see that it's now going to be simple cuboidal epithelium. And then once we get down to the alveolar level, we're going to change over to a simple squamous epithelium. Remember, squamous is those thin and flat cells. And again, advantageous because gas exchange needs to occur over one layer as opposed to 147 layers. And we like the squamous, thin and flat, as opposed to a cube for traveling less distances. All right, now we are down to the alveolar level. So your respiratory tubes and the alveoli. So your bronchial trees, remember, once we get down to the respiratory passage or the respiratory bronchioles, that's where gas exchange begins. Up until then, everything that we've talked about, the trachea, the primary bronchi, all that does is just transports air. It is not for performing gas exchange. Once we get down to those, the respiratory bronchial level, that's where gas exchange starts. The ideal place would be the alveoli, or at the alveolar level for gas exchange. And so we know it's from the respiratory bronchioles to the alveoli. And then during gas exchange, we know that we breathe in oxygen, and oxygen goes from the alveoli through the capillary walls to the bloodstream, and that carbon dioxide goes from the bloodstream through the capillary walls to the alveoli. All right, so during gas exchange, it is simple diffusion. Simple diffusion, remember, is a passive process. It doesn't require ATP. All we are doing is looking at the concentration gradient, and when we breathe in air, typically that's going to be oxygen, and we have more oxygen in the alveoli than we do in our veins. So oxygen is going to diffuse from the alveoli through the capillary walls and enter the bloodstream. On the flip side, the carbon dioxide that the cells produced during cellular metabolism, that blood has just come back through the heart and then to the lungs. That again is simple diffusion. It's going to have a higher concentration in the bloodstream than the alveoli. So carbon dioxide is going to diffuse from the bloodstream through the capillary walls into the alveoli, and then we breathe out the carbon dioxide. So you can see that the alveolus is a simple squamous epithelial layer, and that we have this capillary that surrounds the alveolus. And then the blood flow is kind of like a one direction blood flow. On one side, we have an arteriole, and on the other side, we have a venule. And then remember, we have the blue side to show more deoxygenated blood, and we have the red side to show more oxygenated blood. So on this left side, you can see that this is more deoxygenated blood. And here, after we've done our gas exchange, the blood vessel turns red, even though the blood vessel doesn't turn red. We're just showing the color change to show that now the blood is oxygenated. All right, so here's kind of like the same picture, but you can also see the blood vessels and the capillaries that are surrounding the alveolus. All right, so your lungs themselves, they're really soft, and you'll get a feel for them. You'll actually feel them in lab. They're soft, they're spongy feeling, they're a cone-shaped organ in your thoracic cavity. Your thoracic cavity is kind of like what lies underneath your lungs, and they're separated from each other by your heart and the mediastinum, or the mediastinal cavity. Your right lung has 3 lobes, and your left lung has 2 lobes. And then there's this place called a hilum. And remember, a hilum is just a region that blood vessels enter, nerves might enter. So it's just like a specified area where nerves and or blood vessels enter. We have a hilum on the kidney. We have a hilum in your lymphatic system. So a lot of organs have hilums. And then remember that we have these pleura these double layered serous membranes that are going to surround your lungs. We have a visceral pleura, which is the inner layer that's actually attached to the surface of lung. We have a parietal layer or a parietal pleura, which is the outer layer. And then in between those two layers, we have that pleural cavity, which is going to have that serous fluid in between those. So what happens if air gets into the pleural cavity? Um, if air gets into this pleural cavity or this potential space, you're actually going to develop or get a condition called a pneumothorax. A pneumothorax is a condition in which air separates the visceral and parietal pleura in the chest, and it's going to result in a collapsed lung. And you're going to have a chest tube that is going to be placed, and it's going to kind of suck out that air to kind of to reinflate your lung. All right, so here are your pictures of your lungs. So this is your posterior side or your back side. This is your anterior side or your front side. So this would be your left side and this would be your right side. So here are your lungs. And so this would be your this is your visceral layer. This is your parietal layer. And this in between your visceral and parietal layer, this would be your serous fluid or your pleural space. So this is what would happen. This would be where you would develop a pneumothorax if air gets into this space. So this is where the chest tube would be placed to suck out the air if you have a pneumothorax. So this is where all your serous fluid lives. And this is just your heart. And remember, a lot of your organs have those multiple layers. So here would be your visceral pericardium, your parietal pericardium, and then you would have your serous fluid or your pericardial space. All right, here's just a summary slide of kind of what we've talked about so far. All right, lung irritants. So asbestos, we've heard about asbestos, not so much anymore. We're really dealing with the aftermath of asbestos now. We used asbestos a lot more in the early years or in earlier decades, not so much since 1970s. But it kind of gets into your lungs. We used it a lot in building materials, but it got into your lungs and created more fibrotic scarring of your lungs, which leads to shortness of breath and to different kinds of cancers, lung cancers, some mesotheliomas, and now there's a bunch of lawsuits. I'm sure you can look at those anytime you turn on the TV or research on the internet about, were you exposed to asbestos? Call this law firm and we can get you past compensation. We won't talk really about the next two. Air pollution. We know about air pollution. All right, so air pollution, just a bunch of small particles that can eventually reach the alveoli that might not get filtered out by your nasal hairs, your nasal cavity, or that pseudostratified ciliated columnar epithelium. We saw this a lot in 2001. I do realize that many of you were not born then, but if you remember, or if you don't remember, I'm sure you've heard that, the Twin Towers were attacked on September 11th, 2001. The planes hit the World Trade Center in New York City, among other places. But even in October of 2001, fires were still burning in New York City. And people that were living in New York City at the time still had to be concerned with very small airborne debris particles. They still had to be concerned with air pollution because of something that happened a month prior. All right. Breathing mechanism. So we talked about ventilation. Ventilation is just the movement of air from the outside of the body into your lungs. Ventilation has nothing to do with perfusion. Perfusion is the process of gas exchange. So we know inhalation is taking a breath in, and we know that exhalation is breathing out. And so we have a respiratory cycle, which is one inspiration followed by one expiration. All right, here's when we're going to get into some physics. All right, so we have atmospheric pressure, which is basically going to be the force that moves air into our lungs. And we're going to relate everything to sea level. And at sea level, that's going to be, we're going to relate that to 760 millimeters of mercury. So when we measure our blood pressure, that's in millimeters of mercury. So we can also say that's one atmospheric pressure, or one torr. So when respiratory muscles are at rest, atmospheric pressure and alveolar pressure are equal. So when we are not breathing, when we're just at rest, when we're not moving air, everything is equal. And when those pressure differences, when we have a difference in those pressures, when either atmospheric pressure is greater than alveolar pressure, when alveolar pressure is greater than atmospheric pressure, we're going to see that we are either breathing in or breathing out, or that's causing us to pull air into our lungs or causing us to breathe air out of our lungs. And it's related to this concept of Boyle's law. And if you took physics or chemistry, you're going to know Boyle's law. Boyle's law states that the pressure of volume and gases are inversely proportional. And you can see the formula P1V1 equals P2V2. And that just means that as the volume increases, the pressure will decrease. So to keep everything constant, if one pressure increases, the other, the volume, if the pressure increases, the volume will decrease, or if the volume increases, the pressure will decrease. So as one goes up, the other one will go down. So they're going to move in opposite directions, up, down, or down, up, down, up. And we'll see this. So here, if the pressure inside the alveoli, so we call that the intra-alveolar pressure, if the alveolar pressure decreases, atmospheric pressure is going to push air into the airways. So remember, gases are going to move just like a concentration gradient, just like simple diffusion works. We go from an area of higher concentration to an area of lower concentration. With salt and water, the shear Cuban water. Gases move by the same concept, except now we're going to be moving by a pressure gradient. If the pressure is gradient, the pressure is greater on one side, on the other, air is going to move towards from the higher pressure area to the lower pressure area. So if the atmospheric pressure, if the pressure inside the alveoli is decreasing or is smaller than the atmospheric pressure, then the atmosphere will push the air into the alveoli. And that's going to occur during normal resting inspiration. Your phrenic nerve is going to stimulate the diaphragm to contract downward. Your volume of your thoracic cavity is going to increase. And we're going to see that the pressure is going to basically decrease, which is going to allow for that pressure difference, and air is going to come into the thoracic cavity. And this is just a more simplistic version of Boyle's law. We're not really going to go into this whole plunger thing, but I really don't like this picture, so we're not just going to cover it. So here, atmospheric pressure is always going to remain, not always doesn't mean always. So we're going to say that it's always going to be 760. And at rest, our intrapleural pressure is 756. So remember, our intrapleural pressure is the pressure that's inside of our lungs, and the intraalveolar pressure is the pressure that's inside of our alveoli. So this is what we're really looking at. We're going to be comparing these two right here. The atmospheric pressure versus the intraalveolar pressure. So at rest, we can see that they're both the same. So we don't have any air movement when we're at rest. Obviously, we're not breathing. We're just sitting there. We're not holding our breath. We're not closing off. Typically, when you say hold your breath, you're holding your breath and you're closing off your airway. You can sit there and you can breathe in, and you can leave everything open. You're not closing off your epiglottis. You're not closing off your glottic area. You're not closing off your nasal passages. You're just kind of like, you're not moving any air. So with inspiration, we're still going to have a 760 atmospheric pressure, but your intraalveolar pressure is going to decrease, which means, if we remember, if we go back to our Boyle's law, if one goes up, the other one must go down. Or if one goes down, the other one must go up. So in this case, if with inspiration, our pressure is going down, so therefore our volume must go up. So here our intraalveolar pressure has gone down, so our volume has to increase. On expiration, our atmospheric pressure stays the same at 760, but our intraalveolar pressure has increased. So our pressure has increased, therefore our volume decreases. So you're going to need to know what happens with pressure changes during inspiration regarding the intrapleural pressure and intraalveolar pressure. So you're going to need to know the numbers as well. You're going to need to know definitely the concept of pressure and volume. When one goes up, the other one goes down, and how that they are inversely proportional. The For inspiration, you're going to have to know that the intrapleural pressure decreases a little bit, and that the intrapleural pressure decreases, which is going to cause the atmospheric pressure to push air into the airways. So your volume is going to increase. So your volume of the thoracic cavity and the volume of your lungs is going to increase. All right. Now, so with inspiration, so when we breathe in and when we breathe out, we have two types of breathing. We have this thing called quiet breathing and forced breathing. Quiet breathing is when we're sitting there reading a book or whatever, studying like you guys do a lot, I'm sure. And that's just when we're breathing. We're not thinking about it. We're just doing it. You have a normal, regular breathing rate and pattern. You're breathing in, you're breathing out at the same time and the same volume. In normal, quiet inspiration, it's a resting inspiration. Air is going to move into the lungs because of those pressure gradients between the atmosphere and the alveoli. That is Boyle's law. That's what we just talked about. Your diaphragm and your external intercostal muscles are going to work. They're going to contract, and they're going to enlarge your thoracic cavity. They're going to increase the size of your thoracic cavity. You're going to see that your lungs are going to expand because that surface tension in that pleural cavity. And then surfactant is there. Surfactant reduces the tension in the alveoli to help with lung expansion. And we'll talk about surfactant here in a second. Now, we also have this type of breathing called forced breathing or deep breathing or maximal inspiration or forced inspiration, whatever you want to call it. And that is when you breathe in more deep or deeper than you normally would. So that's when you like take a deep breath or take a breath faster than you normally would. So like when you, and that uses more muscles than just your diaphragm and your external intercostal muscles. So normally with quiet breathing, we're using your diaphragm and your external intercostals. When we're doing a forced inspiration, we're also using our pectoralis minor muscles, your sternocleidomastoid, and your scalenes. And I said, surfactant. So surfactant, I said reduces that surface tension in the alveoli, and it helps keep your lungs open. So it's produced by the alveoli, and it helps keep your lungs inflated. It helps keep those alveoli open. It helps keep those alveoli from collapsing. Surfactant typically develops around the 35th week in gestation. So if you have like a premature newborn, just be very careful about them developing like a respiratory distress syndrome because they don't have sufficient levels of surfactant. So just something to keep in the back of your mind if you're going into peds. All right, so with quiet breathing or movements with inspiration, you're going to have to know this slide. So your impulses are going to act on your phrenic nerve, on the diaphragm. Your diaphragm is going to contract, and that dome-shaped diaphragm is going to move downward. Your thoracic cavity is going to expand. Your external intercostals are going to contract. That's going to raise your ribs, allowing your thoracic cavity to expand even further. That's going to cause your intraalveolar pressure to decrease. And now your intraalveolar pressure, which is 700, or I'm sorry, your atmospheric pressure, which is 760, is going to be greater than your intraalveolar pressure. And remember, if we go back to that slide, it's going to be 758. And that's going to force air into the respiratory tract through your air passages. Because remember, air is going to follow that pressure differences. Those pressure differences in your lungs are going to fill with air. Now, on the flip side, we have expiration. Expiration is, we can call it a quiet expiration or a normal resting expiration. Again, we're sitting here breathing, inspiration, expiration. It's a normal. We're not a normal process. We're not doing anything special. We're just sitting there breathing. Typically, that is due to our expiration is due to a normal elastic recoil of lung tissue, where your tissues and your organs are going to return to their original shape and position at the end of inspiration. And we have this surface tension that's going to develop, and the alveolar linings are going to shrink the alveoli back to their original level, or back to their original position. And now these factors are going to increase the intraalveolar pressure above atmospheric pressure, forcing air out of the lungs. And it's a passive process, so it doesn't require ATP. And it doesn't involve muscle contraction. But we also have this forced expiration, or a maximal or forced deep expiration, where we do use muscle contraction. If you exhale very quickly, you would use your abdominal muscles. You could actually physically use your diaphragm to push air out of your lungs. You're going to use your intercostals and your abdominal muscles. Here, you would see that, during normal quiet breathing, your diaphragm is going to relax. Your external intercostal muscles are going to relax. That's going to lead to that elastic recoil, or that normal recoil that allows that surface tension to push in on the alveolar walls. And then now we're going to compare the intraalveolar pressure. So that intraalveolar pressure is going to be greater than the atmospheric pressure. So because of the pressure now is greater on the inside, or the alveoli, than the atmospheric pressure, air is going to be forced out of the lungs. So again, you're going to need to know this chart. But the main thing here is that during quiet breathing, no muscles are being contracted. The only time we use muscles for expiration is when we do a forced contraction, or a forced expiration, or a deep expiration. And that's when we're going to use our internal intercostal muscles and our abdominal muscles. All right, now we're going to be moving on to something that you probably aren't going to like. Respiratory volumes. So we have different volumes of air that we can move in and out of the lungs. We talked already about um, normal quiet breathing where we just sit and we just breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. That is actually something that can be measured. We actually call that a tidal volume when we sit there and we breathe in, breathe out. You know that we could take in a maximum breath. We can breathe in as a big, big, big breath. And we can breathe out as much as we can. Those are something that we can measure. So we can use this thing called spirometry to measure different air volumes. And when we do spirometry, we actually use that to judge the progression of different respiratory illnesses like emphysema, pneumonia, bronchial asthma, or lung cancer. And when we do this spirometry test, it might require you to breathe normally, but it might require you to put forth some effort in order to move air in and out of your lungs. It might require you to breathe in and out to maximum capacity. We have this measurement called a vital capacity, and that's the maximum volume of air that can be exhaled after taking the biggest breath possible. So vital capacity is going to be where you take the biggest breath possible and then you exhale as much air as you can. That's called the vital capacity. And then we also have different capacities that can be calculated by combining two or more respiratory volumes. And with a lot of these, they can vary depending on gender, body size, age. All right. This is the chart or the word version of the respiratory volumes and capacities. This chart is based on, or these values are based on a tall young adult. So here you can see, we talked about the tidal volume, and we abbreviate that as TV, or sometimes you'll see it as V sub T. And it's the volume of air that's moved in and out of the lungs during a respiratory cycle. Just a normal, quiet breathing. And it's going to be about 500 milliliters. We have this inspiratory reserve volume, and that's the maximum volume of air that can be inhaled at the end of a resting inspiration. So you take a normal breath in, so you're quietly breathing, and you take a normal breath in, and then you inhale as much as you can. That would be your inspiratory reserve volume. And it's going to be about 3,000 milliliters. So you take you breathe in, you breathe out, you breathe in, you breathe out, you breathe in, and then you breathe in as much as you can. That's your inspiratory reserve volume. On the flip side, your expiratory reserve volume is the maximum volume of air that can be exhaled after a respiratory expiration. So you breathe in, you breathe out, you breathe in, you breathe out, you breathe in, you breathe out, and then you breathe out, breathe out, breathe out, breathe out, breathe out. That is your expiratory reserve volume. And then we also have this thing called a residual volume. That is the volume of air that remains in your lungs after a maximum expiratory effort. So we know that you really can't breathe out all of the air in your lungs. There's always going to be some air left in your lungs. We can't collapse your lungs 100%. And so we're going to calculate that volume to be 1,200 milliliters or 1.2 liters. And I forgot to tell you that the ERV is about 1,100 milliliters. So scientists have measured or calculated this residual volume to be 1,200 milliliters. Vital capacity. Vital capacity is a measured calculation based on your tidal volume plus your inspiratory result volume plus your expiratory result volume. It is the maximum volume of air that can be exhaled after taking the biggest breath possible. So you breathe in as much as you can and you breathe out as much as you can. That is your vital capacity. The amount of air that you can breathe in and breathe out. As much air as your lungs can hold is your vital capacity. And it's going to be about 4,600 milliliters. Your inspiratory capacity is basically how much air that you can inhale, how much air can you inhale completely. So that is going to be based on your tidal volume plus your inspiratory reserve volume. So you breathe out as much as you can, and then you take the biggest breath possible. That is your inspiratory capacity, and it's going to be about 3,500 milliliters. 3,500 milliliters. Your functional residual capacity is your volume of air that remains in the lungs following expiration of a residual tidal volume or resting tidal volume. So you breathe in, you breathe out, you breathe in, you breathe out, and then the volume of air that remains in your lungs would be your functional residual capacity. So the expiratory reserve volume plus that residual volume, what you can't breathe out. And we estimate that to be 2,300 milliliters. And then your total lung capacity, that is about 5,800 milliliters. That is going to be the volume of air that your lungs can hold. So your vital capacity, which is the biggest breath that you can breathe in and out, plus the amount of air that your lungs can't breathe out. And we say it's about 5,800. And I'll just show you, we're going to come back to this slide, but I'll just show you this picture. You're going to have to know this picture inside and out. I can promise you that right now. Whether it be for this exam, for your nursing boards, if you go for a nurse practitioner, if you go to anesthesia school, especially if you go to anesthesia school, you're going to have to be able to draw this picture. You're going to have to know this inside and out. So here is our normal tidal volume. This is our quiet breathing. Breathe in, breathe out, breathe in, breathe out. And then this is when we breathe in, breathe out, and then we take a deep breath in. And then that is our inspiratory reserve volume. Breathe in, breathe out, and then we breathe out as much as we can. That's our expiratory reserve volume. That residual volume of 1,200 milliliters, that's what scientists have estimated our residual volume to be. Our functional residual capacity is our expiratory reserve volume plus our residual volume. Remember, our vital capacity is our biggest breath in plus our biggest breath out. It's the maximum air that we can breathe in, a maximum amount of air that we can breathe in and breathe out. Here you can see the different additive values. Your inspiratory capacity is your tidal volume plus your inspiratory reserve capacity. Your vital capacity is your IRV plus your tidal volume plus your ERV. Your total lung capacity is your inspiratory reserve volume plus your tidal volume plus your functional residual capacity. Your functional residual capacity is your expiratory reserve volume plus your residual volume. So you're going to have to know your equations. You're going to have to know a lot of things either on this slide or this slide. So what do you really have to remember? You're going to have to know the names. You're going to have to know the descriptions. You do not need to know the volumes. I will say there's some exceptions. We'll get to those in a second. But for the most part, you will not need to know the volumes. But you will need to be able to put these in order according to their volumes. So you will need to know that the total lung capacity is the highest volume, followed by the vital capacity, followed by the inspiratory capacity, followed by the inspiratory reserve volume, followed by the functional residual capacity, followed by the reserve volume, followed by the expiratory reserve volume, followed by the tidal volume. You will need to know how to calculate and interpret all of these equations on here as well. For example, you're going to have to know the volume of the additional air that enters the lungs during maximal inspiration. That's called the inspiratory reserve volume. You're going to have to know how to calculate that. All right, I said that all right, so here, let me just do some erasing. All right. So, like I said, these values are for a tall young adult. So we're going to look at tidal volume real quick. Tidal volume is, we'll look at the science a little bit behind tidal volume. Tidal volume can be estimated. It's actually estimated based on your ideal body weight. We call that IBW, ideal body weight. And if you're in a male, your ideal body weight is going to be, we do this in kilograms. So 50 kilograms plus 2.3 times your height in inches minus 60. And that's how we would come up with your ideal body weight. And then if we were looking at the ideal body weight of a female, we would do 45.5 kilograms plus the 2.3 height in inches times height in inches minus 60. So your tidal volume would actually range between, and I've always abbreviated tidal volume this way. I know the book abbreviates tidal volumes TV. When you get in the real world, you'll see the tidal volume is most often abbreviated BT, so I'm going to use that. Your tidal volume actually ranges between 6 and 8 times your ideal body weight, milliliters per kilogram of your ideal body weight. You really don't need to know that, but I just wanted you to know that your tidal volume is based on your ideal body weight. All right, and we'll come back to that. So you don't have to know the formulas, but I just wanted to give you the science behind ideal body weight and tidal volume, because we are going to come back to that a little bit later on. All right, so on the whoop. All right, so remember that I said that most of these things can be measured. This residual volume cannot be measured. We can measure everything with spirometry except the residual volume. And because of that, we truly can't calculate the functional residual capacity and the total lung capacity. So the residual volume, the total lung capacity, and the functional residual capacity, those are all estimates based on this 1,200 milliliters that we're estimating the residual volume to be. And here you can see that the expiratory reserve volume is about 1,100 milliliters. So 1,100, and we see the formula FRC equals ERV plus RV. So ERV is 1,100 plus 1,200 gives us 2,300. Here you can see that the total lung capacity is vital capacity plus plus RV. So our vital capacity is 4,600 plus 1,200 equals 5,800. So you can see how the equations do work based on the estimate of 1,200. Now, I said that you don't have to memorize the actual numbers, with some exceptions. So you do have to memorize, or you will have to know these two volumes. You're going to have to know that tidal volume is going to be around is 500 milliliters. You're going to have to know that the inspiratory reserve volume is 3,000 milliliters. And I say that because there are a couple math questions that are based on these two calculations. The math questions you really don't need a calculator for. They're gonna be worded a little bit differently, but they're gonna go something like this. And I'm changing the wording just so that I don't give you the exact question. I'm going to change the numbers a little bit just so that I don't give you the exact numbers that are on the exam. But, let's say that you're training to be a firefighter, and you're learning how to use the oxygen tanks that are on your back. That, you go into the fire, and you have to use the oxygen tanks. And let's say you're in training, and you look at the gauge on the tank, and the gauge says 15,000 milliliters. And then as you start your training, you're brand new and you freak out because now you have the tank, the fire gear, your mask, your axe. You're not used to all of this. You're claustrophobic, and you're really freaking out. And you start taking full inspiratory reserve volume breaths each time you inhale. How many times can you inspire at this panicked volume before your tank runs out? So as you start your training, you start to freak out and you start taking full inspiratory reserve volume breaths each time you inhale. All right, so when we do this, our gauge read 15,000. And then it says that we're taking full inspiratory reserve volume breaths, which is 3,000 milliliters. That's going to equal 15,000. 15 divided by 3 is 5 times. So you're pretty much only going to be able to take 5 breaths at that panicked level before your tank runs out of oxygen. Now that you have had practice with breathing through this oxygen tank and you have experience and you're not so panicked, you've learned how to meditate. Now let's say that you can control yourself and your temperature or your gauge still says 15,000. And now you are taking regular tidal volume breaths. How many times can you breathe before your tank runs out? Let's see, 150 divided by 5 is 30 times. So that's how you would complete those questions. And then, like I said, there's 2 of them on the exam. All right, so here is the picture version of what we talked about. Like I said, whether it's this slide or this slide, you will need to know this inside and out. All right, dead space. So we have, some of the air that we breathe in doesn't necessarily reach the alveoli, and those are called dead spaces. If you breathe in air, we still have air in our nose, we still have air in our pharynx, we still have air in our larynx, we still have air in our trachea, we still have air in our bronchi. All that air doesn't reach the alveoli for gas exchange. So some of the air that we breathe in doesn't reach all the way to the alveoli before we breathe it out. And all that stuff is called dead space. So we have anatomic dead space, which is the portion of inhaled air that doesn't reach the alveoli and it doesn't participate in gas exchange. And then we also have alveolar dead space, and that is air that does reach the alveoli, but it doesn't participate in gas exchange because those alveoli are non-functional. So think of like conditions that are where you have non-functioning alveoli. Could be, cystic fibrosis or emphysema or something like that. So, these cases are going to be, very occasional. So unless you have a pathologic condition or physiologic condition that prevents gas exchange, we're not really going to normally have alveolar dead space, but we're always going to have anatomic dead space. So we can say, we can say physiologic dead space is going to be a total of your anatomic dead space plus your alveolar dead space. And I don't need the total. So your physiologic dead space is your anatomical dead space plus your alveolar dead space. And remember, your alveolar dead space is only when we have a disease process that prevents alveoli from participating in gas exchange. So that doesn't occur in a normal person. So under normal circumstances, anatomic dead space is going to equal physiologic dead space, because in a normal person, under normal circumstances, alveolar dead space is non-existent. And we can abbreviate physiological dead space as PDS. And usually, if we look at the volume of air that's in our nasal cavity, or in our nose, in our nasal cavity, in our pharynx, in our larynx, in our trachea, in our bronchi, in our bronchioles, and our lobars, and our segments, and everything that doesn't participate in gas exchange, we say that that's about 150 breaths per minute. And the range is going to be anywhere from 100 to 285 milliliters, depending on your age, sex, obesity status, your size. So, but just remember, 150 milliliters per breath is going to be about what your dead space is going to be. All right, so now we can say this minute ventilation. Minute ventilation is the volume of air that's moved into the respiratory passages each minute. So how much air do we breathe in through our nostrils each minute? So we can calculate that based on our tidal volume times our respiratory rate. And we typically, even though this chart says our tidal volume is expressed in milliliters, typically this equation, we're going to express it in liters. So if you express it in milliliters, I really don't care, but just know that the test might have either milliliters or liters on it. So you might have to convert it from milliliters to liters. And so, just know that you might have to do that conversion. So the formula, minute ventilation is tidal volume times respiratory rate. So TVE times RR. So, you have a patient that's breathing 12 times per minute. That's a normal respiratory rate. Remember, most textbooks will say 12 to 20 is normal. Some textbooks will say 12 to 16 is a normal respiratory rate, and is in no apparent distress. So because I see that no apparent distress, I can assume a normal quiet inspiration and a normal quiet expiration. That's what no apparent distress means to me. So in that case, because I have no apparent distress, I would assume a tidal volume of 500. All right. So all I'm going to do is do my calculations. Tidal volume, remember, is in liters now. So remember, 1 liter equals 1,000 milliliters. So 500 milliliters would equal 0.5 liters. All right, so 0.5 liters times 12 breaths per minute, that would give us a minute ventilation of 6 liters per minute, or I could say 6,000 milliliters per minute. And that is my minute ventilation. So I would have 6,000 milliliters or 6 liters of air entering my nasal passages or my respiratory passages each minute. And that's minute ventilation. Alveolar ventilation takes into account that physiologic dead space. So remember that we have that anatomic dead space, and in some cases that physiologic dead space, or that that alveolar dead space. If we have a diseased alveoli that doesn't participate in gas exchange, but so we might have to take that into consideration, but. So alveolar ventilation is where we take into account that dead space. So alveolar ventilation is the volume of air that reaches the alveoli each minute. So now we're looking at the amount of air that's going to the alveoli to participate in gas exchange. So the formula is going to be very similar to minute ventilation, but now we're going to kind of subtract out or take into account that physiologic dead space. So again, here we can express, actually this formula you can express tidal volume and physiologic dead space in liters or milliliters. So here you would take your tidal volume minus your physiologic dead space, and then multiply that by your respiratory rate. And I will say, it says alveolar ventilation. Some people will write that as your alveolar ventilation rate, or AVR. So sometimes you might see alveolar ventilation or alveolar ventilation rate. So again, we have our person that's 12 times per minute, no apparent distress. When I see no apparent distress, I'm going to assume tidal volume of 500. And because we are talking about alveolar ventilation, we have to take into account our physiologic dead space, which we learned earlier was 150 milliliters per breath. So here, we do our tidal volume minus our 150 milliliters. Remember, 150 milliliters would equal, if we move that decimal point over, would equal 0.15 liters. That's how we come up with this number. And then we multiply that by 12 breaths per minute. So our alveolar ventilation, or our alveolar ventilation rate, would be 4.2 liters per minute, or 4,200 milliliters per minute. And that just lets us know how much oxygen and carbon dioxide are in the functioning alveoli. Now, tidal volume. So we talked about tidal volume, and I went off on this tangent about ideal body weight. And I said we come back to that later. So we have this equation, and this whole physiologic dead space. I'm going to see if I can just, well, so, okay, so let me just do some erasing here first. So I put this equation up there. So we have this alveolar ventilation that's based on the tidal volume, the physiologic dead space, and the respiratory rate. So this physiologic dead space was actually based off this method. It was measured using this thing called the Bohr-Enghoff method, and this is the equation that they used. We're not going to go into the science behind it and what all the letters mean, but basically this physiologic dead space is looking at the difference between the exhaled carbon dioxide level and the alveolar carbon dioxide level. And we talked about how we can estimate the ideal body weight a few slides ago. And the equation on this slide right here is basically a very rough estimate in determining the alveolar ventilation rate in the physiologic dead space. We could actually use another equation that could more accurately determine the alveolar ventilation rate or the alveolar ventilation based on your carbon dioxide output and the arterial carbon dioxide tension. I put that equation there for you. But, it would require, sticking catheters in your arteries and doing these measurements and blood draws. And, we don't have time for that. We don't have the equipment to do that. It's much easier to kind of estimate everything, come up with a number that is very close to the actual number. This is not rocket science. So, 40, when we came up with 4,200, when we came up with 4,200 or 4.2 liters per minute, that is a very rough estimate of your alveolar ventilation. If we actually did this and looked at the true numbers, we might come up with 4.1974 liters per minute. And I'm fine with this 4,200, which is very close to the 4.197. So I just threw in these equations just to show you, and you don't have to know these. We're not going into any in-depth as to what these equations even mean, but I just wanted to let you know that what we're doing is actually a very rough estimate of the alveolar ventilation. All right, so non-respiratory air movements. So we have movements, the coughing, the sneezing, the hiccuping, the laughing, the crying, that, do move air in our respiratory system, but, and it's usually as a result of a reflex. And, laughing and crying might start voluntarily. And so here they are. You're going to have to know this chart in depth. You're going to have to know what a cough is, what a sneeze is, what the functions are. But I think you already know all of these, and you can figure out what they are just based on your knowledge. I think that that a laugh is a deep breath that's released in a series of short expressions, and that it measures happiness. I think that as a cry is pretty much the same as a laugh, but that it expresses sadness. You might have to learn what a cough is and how the glottis is opened versus glottis is closed and the blast of air passing. But I think that a cough will clear the lower respiratory passages, whereas a sneeze clears the upper respiratory passages. So definitely know this chart. All right, with certain diseases, we can decrease ventilation and perfusion. So remember, ventilation is the air movement or just air movement in and out of the lungs, and perfusion is gas exchange. So bronchial asthma is usually just an allergic reaction. You go outside and you inhale pollen and you have this antigen reaction. And with bronchial asthma, and you use your inhaler and you have the bronchodilation to counteract that bronchoconstriction of that antigen reaction. And so with bronchial asthma, usually those allergens are going to irritate that smooth muscle, which leads to the bronchoconstriction, and you have wheezing, and you have a difficulty with breathing out or exhaling. And there's a trick of the trade that you should remember. If you have difficulty inhaling, you're going to have stridor. And if you have difficulty exhaling, you're going to hear wheezing. So if you hear stridor, think of inhalation problems. If you hear wheezing, think of exhalation problems. So with bronchial asthma, you're going to hear wheezing, so it's going to be an issue with exhalation, usually as a result of an allergic reaction, and usually controlled with an inhaler. With emphysema, we talked a little bit about emphysema earlier. This is a problem with the alveoli themselves. The alveolar walls are actually destroyed. It's a progressive degenerative disease usually caused by smoking, where the alveolar walls kind of disintegrate. And think of like that grape cluster, and you kind of pick out some of the grapes, and you have half of the grapes that are still there, and half the grapes that are gone, and that grape cluster now that are half gone, they kind of merge together. And so those alveoli, they are going to merge together and form larger ones. And as they merge together, because you don't have the membranes of all the original alveoli, the surface area of the new alveoli are going to be decreased. So you're going to decrease that surface area for gas exchange. The alveolar walls, they're going to lose elasticity, and the capillaries are going to diminish. The capillaries aren't going to be as prevalent as they were prior to the alveolar walls being destroyed. And it's going to take a lot of effort in order to pull air into your lungs. So you're going to see inspiratory effort and expiratory effort. So you're going to see a lot of accessory muscle use. So you would see the muscles used, like if you were doing like a forced inspiration and a forced expiration. So if you go back to those slides where we talked about the muscles used for forced inspiration, forced expiration, your scalenes, your sternocleidomastoids, your internal, external, intercostal muscles. Those are going to be your accessory muscles that are going to be used for breathing with emphysema. Emphysema is included in a broader category of diseases called COPD, chronic obstructive pulmonary disease, and chronic bronchitis is also part of COPD. So emphysema by itself is a ventilation problem. It is a ventilatory disease in that it's harder to move air in and out of the lungs because you have that accessory muscle use. But because of the pathophysiology of emphysema, in that we decrease the surface area for gas exchange, it is also a perfusion disorder or disease as well. And here you can just see the decreased alveolar walls with emphysema. So on the left, you can see the normal lung tissue, and on the right, you can see how the capillaries have left the alveoli, and how the alveolar walls have kind of been destroyed with emphysema. All right, so control of breathing. Normally we breathe at normal tidal volume, which is about, 500 milliliters. We've already learned that. Breathing typically is going to be an involuntary or unconscious or subconscious movement. We don't necessarily control our breathing automatically. We can, and we can do the forced inspiration, forced expiration, or we can control our tidal volume, but normally it's going to be controlled on an unconscious area or involuntary control. But we do have areas in our brain that, more specifically our brain stem, that control our breathing. And these impulses travel through or travel on our cranial and spinal nerves that allow us to breathe in and breathe out, and they adjust our rate of breathing. They make us breathe faster and breathe slower, and they also adjust our depth of breathing. And our rate and depth of breathing, we'll learn later on in this chapter, is due to the amount of carbon dioxide in our bloodstream. So our carbon dioxide levels is what controls our rate and depth of breathing. We'll see why later on. And we have a main respiratory area, two main respiratory areas. One is called the medullary respiratory center. It's located in the medulla oblongata, and it contains two groups of neurons. One is called the ventral respiratory group, which sets the basic rhythm of breathing, and one is called the dorsal respiratory group, which modifies the activity of the ventral group. So if you have any tumors that affect your rate of breathing, that is going to affect the dorsal respiratory group. So any abnormal or irregular movements that occur during inspiration, that will affect the dorsal respiratory group, and responses to sensory input are delayed and abnormal. Let's see. All right. And we also have another main respiratory control area. It's called the pontine respiratory group. That's located in the pons, and that's going to set the rhythm of breathing by limiting the duration of each inspiration. So know the two main groups, the medullary respiratory center and the pontine respiratory group. One is in the medulla and one is in the pons. You're going to need to know that the ventral group sets the basic rhythm and the dorsal group modifies the activity of the ventral group. Here you can see the pontine affects the medullary, and that the dorsal modifies the activity of the ventral group, and they both affect the respiratory muscles, and affects the basic rhythm of breathing and changes in the rate and depth of breathing. You can see up here the pontine respiratory group lies in the pons. And so you can see the pons is this little outbulging section of the brainstem. The medulla oblongata is just inferior to the pons. So you have the dorsal and the ventral respiratory group. All right, so how do gases move? So remember that when we talk about ion movement, typically we talk about areas of higher concentration to an area of lower concentration, and we have simple diffusion. The same concept applies to gases. We're still going from an area of higher concentration to an area of lower concentration. We saw that when we talked about breathing, and we talked about, the 760 atmospheric pressure going to 758 atmospheric pressure. So we're still talking about a higher concentration, an area of lower concentration, but we're not talking about necessarily a concentration per se. So we're talking about a pressure. So we're going to talk about partial pressure of gases, and we're going to relate that to the concentration. So we're going to use the terms concentration and partial pressure interchangeably, but we're really gonna say partial pressure of gas. But you can think about it as the concentration of gas. So a partial pressure is just the amount of pressure that each gas contributes to the total pressure. So if we're looking at air, so if we're looking at air per se, air is made up of 21% oxygen, 78% nitrogen. And then we have a little bit of carbon dioxide, a little bit of neon, a little bit of hydrogen. Those are pretty much negligent. So we're going to say that air is 21% oxygen, and we know that atmospheric pressure is 760 millimeters of mercury. So we would just take the 21% as 0.21, because remember, we moved the decimal place over 2 times or 2 places to convert a percentage to a decimal. And we would take that times 760 to get 160. So we would say that the partial pressure of oxygen is 160 millimeters of mercury, and we designate that as P sub O2. And that's how we kind of write, or we use the terminology or the lingo of saying partial pressure of oxygen being 160. And then on the flip side, if we did nitrogen is, what did I say, 78%. So we would do, let's do 78% times 760. So the partial pressure of nitrogen would be 592.8 in atmospheric air. All right, so the partial pressures are how we determine the relative amount of gases in the mixture instead of saying the concentration. So, like I said, we can use the terms interchangeably, but we're not saying concentration anymore. We're saying partial pressures. So you don't necessarily have to do the math behind this, but you do have to know the concept of what we're talking about. Now, what affects our rate of breathing and our depth of breathing? And I told you before that it's going to be the partial pressure of carbon dioxide. So let me put that one first. Partial pressure of carbon dioxide, or we can abbreviate that as PCO2 in our body fluids. But to some extent, the partial pressure of oxygen, what's the hydrogen ion concentration in our body fluids. We'll see how carbon dioxide and hydrogen ion concentration are correlated. The degree of stretch of lung tissue. We kind of briefly covered that with emphysema and how the elastic recoil, not necessarily with emphysema, but with exhalation, that elastic recoil of the lungs and the lung tissue. And also with emphysema, you don't have that necessarily that elastic recoil, and you have to use your accessory muscles to exhale. Your emotional state affects your rate of breathing. When you cry or laugh, you have an altered rate of breathing. Your level of physical activity, if you exercise, you're going to breathe faster than if you're not exercising. We have receptors, mechanoreceptors, we call central and peripheral chemoreceptors that will affect our rate of breathing. And then I said before, mainly controlling factors are the PCO2 and the hydrogen ion concentration. We'll see how those two are interplayed. And we'll see that the rise and fall of carbon dioxide and hydrogen will go in the same direction. So if we have a rise in carbon dioxide, our hydrogen ions are going to go in the same direction. If our carbon dioxide increases, our hydrogen ions are going to increase. If our carbon dioxide goes down, our hydrogen ion goes down. Our hydrogen ion concentration goes down. And or you should know by now, that hydrogen ion determines pH. So if our hydrogen ion concentration goes up, our pH goes down. And if our hydrogen ion concentration goes down, our pH goes up. So now you could say that if our carbon dioxide levels increase, our pH decreases. And if our carbon dioxide decreases, our pH increases. So you could put all three of them together. If our carbon dioxide goes up, our hydrogen ion concentration goes up, and our pH goes down. If our carbon dioxide levels go down, our hydrogen ion concentration goes down, and our pH will go up. And we'll make this more clear as we go through the rest of this chapter. So I said that we have these central chemoreceptors and peripheral chemoreceptors. So peripheral or central chemoreceptors, they're going to be located on the ventral part of the medulla oblongata near the origin of the vagus nerve. Remember, the vagus nerve is cranial nerve number 10. And I'm seeing if there's something else that I want to say about that. All right. And they're going to mainly monitor the pH in the brain. And since we're monitoring the pH of our brain, we're monitoring our hydrogen ion concentration. So in effect, we're also looking at our carbon dioxide level. Because remember, carbon dioxide and hydrogen ion concentration go hand in hand. And we will see that carbon dioxide and hydrogen ion concentration, they will go hand in hand, and we'll see that on slide 72. So because carbon dioxide and hydrogen go hand in hand, our partial pressure of oxygen really doesn't have anything to do with our central chemoreceptors, even though I told you that our partial pressure of oxygen controls the depth of breathing. And we'll get into that, how the partial pressure of oxygen deals with breathing later on. So hydrogen ions, they don't cross the blood-brain barrier too well, but carbon dioxide does cross that blood-brain barrier, and it'll bind to water and produce this H2CO3 carbonic acid. And then it says slide 72, and we'll see that that carbonic acid will dissociate to release hydrogen ions, which are detected by these central chemoreceptors. So CO2 binds to water, CO2 will bind to water to produce this carbonic acid, which will dissociate, and this is a double arrow, which will dissociate into hydrogen ions plus bicarb, HCO3 minus. And this is the equation that we'll see on slide 72. So remember, hydrogen ions don't cross that blood-brain barrier, but CO2 will. And once CO2 does, then this whole process can happen. And remember that hydrogen ion concentration is directly linked to CO2, so that CO2 goes up, hydrogen ion concentration goes up. CO2 goes down, hydrogen ion concentration goes down. So think of those as being equivalents when we are talking about acidity. So acidity is basically your pH. So, and pH measures your hydrogen ion concentration. So if I asked you if this solution has, a lot of hydrogen ions, you would say, oh, well, that's acidic. Well, if I also said this solution has a lot of carbon dioxide, you would say, oh, well, it's acidic as well, because CO2 directly mirrors hydrogen ion concentration. So think of hydrogen ion and CO2 levels as being the same thing. So high CO2 is the same thing as high hydrogen ion concentration. So we're going to have a very acidic environment. All right, increases in hydrogen ion concentration or CO2 in the blood leads to increased alveolar ventilation. All right, so what does that mean? So if we have an acidic environment, so we have an increase in our CO2, which means we have an increase in our hydrogen ion concentration, which means we have a very low pH. So we are acidic. We need to breathe off some of that CO2. We have too much carbon dioxide in our bloodstream. We need to breathe off some of that CO2. That's what this increased alveolar ventilation means. We need to blow off some of that CO2. So we go back to our alveolar ventilation or alveolar ventilation rate formula. We're going to increase our respiration rate, or we are going to increase our tidal volume. Remember, we can't do anything about our physiologic dead space. Remember that alveolar ventilation rate, that formula, alveolar ventilation equals our tidal volume minus your physiologic dead space times your respiratory rate. So we would increase our alveolar ventilation rate by either increasing our tidal volume or by increasing our respiratory rate or by doing both. That would lead to an increase in our alveolar ventilation. So basically, our partial pressure of CO2 is our drive to breathe. Our PCO2 is what makes us breathe. If we have too much CO2, we're going to increase our alveolar ventilation by increasing our tidal volume or our respiratory rate to blow off some CO2. If we have too little CO2, we have too little hydrogen ions, we're going to decrease our tidal volume, or we're going to decrease our respiratory rate, or both, to decrease our alveolar ventilation rate. So if we have an increase in our PCO2, we're going to increase our rate, and I guess I should say, and or our depth of breathing. So as a CRNA, if I have you put under for surgery and I want to wake you back up and I want you breathing again, what I can do is I can put CO2 I can put carbon dioxide in your anesthetic gas mix to increase your blood levels of your carbon dioxide, to stimulate your central chemoreceptors to make you take a breath, to increase your rate and or depth of breathing. Or what I can do is, while you're on the ventilator, I can control your respiratory rate. I can make it say, I want this patient to breathe 10 times a minute, 12 times a minute, 87 times a minute if I wanted to. So when it's time to start waking you back up, what I do is I would turn your respiratory rate down to 8 times a minute to start letting that carbon dioxide build up in your bloodstream. And when that carbon dioxide builds up in your bloodstream, it's going to trigger your central chemoreceptors. Remember, that are on your medulla oblongata, that's near the origin of your vagus nerve. And those central chemoreceptors, once that carbon dioxide builds up in your bloodstream, it's going to trigger your central chemoreceptors to initiate that breath. So I'm going to try and stimulate you to take a breath by increasing the carbon dioxide levels in your bloodstream. Peripheral chemoreceptors are going to be located in the aortic arch and in the carotid bodies. Remember, your aorta comes off your heart and it kind of loops around and goes down in your abdomen. So the aortic arch is that little arch that comes off of the top part of your heart, and then your carotid arteries are here. And this is going to sense changes in your blood PO2. So this is where your partial pressure of oxygen comes in. And so decreased PO2 levels are going to stimulate your peripheral chemoreceptors, and that's going to increase your tidal volume and your respiratory rate. So this is where your PO2 comes into play. So your low oxygen levels will stimulate your peripheral chemoreceptors, hopefully leading to an increase in alveolar ventilation. So your central chemoreceptors are gonna be a result of your carbon dioxide levels, and your peripheral chemoreceptors are gonna be stimulated as a result of your oxygen levels. And they both are going to lead to increase in alveolar ventilation by increasing your respiratory rate and or tidal volume. And I guess here I should write and slash or tidal volume as well. Now, the caveat to this is that your peripheral chemoreceptors, they usually don't cause a major response until your PO2 decreases to about 50% of the normal value. And we'll get into that statement a little bit later on. It's going to be hard to stimulate your peripheral chemoreceptors. So we're going to keep this 50% of normal value kind of in the back of our mind. And we'll see how low do we have to get in order to stimulate our peripheral chemoreceptors. All right, Herring-Brewer reflex. So the Herring-Brewer reflex is basically going to help regulate our depth of breathing. And as we take a deep breath or as we breathe in, our lung tissues are gonna stretch, and we have these stretch receptors that are stimulated, and those impulses are going to travel over our vagus nerve, which is cranial nerve number 10, to our respiratory areas, which are located in the brainstem, and these inspiratory bursts are then shortened to prevent overinflation of the lungs during breathing. And that's just what the Herring-Brewer reflex is. So here you can see how we stimulate or how control of ventilation is controlled by chemoreceptors. So we have, remember, chemoreceptors are CO2 based. So we have the increased in our CO2 levels go high, they are increased. So we have an increase in our blood pH, or a decrease in our blood pH. We have an increase in our hydrogen ion concentration, because remember, our CO2 and our hydrogen ion concentration goes in the same direction. Our pH goes down. That's going to stimulate our aortic and carotid bodies, which is on the peripheral side. And that's going to go up to our medulla oblongata, stimulate our respiratory muscles. We're going to increase our ventilation rate and our depth of breath, and it's a negative feedback loop. So here you can see, there's our medulla oblongata. Here's your carotid bodies and your carotid arteries. Here's your aortic arch. All right. Here's the Herring-Brewer reflex. Not much to say about that, just the vagus nerve. All right, so factors that affect breathing, stretch of lung tissue, low plasma oxygen. We have those peripheral chemoreceptors. High plasma CO2 was our central chemoreceptors. our hydrogen ion concentration. Basically, all of these are going to, these three are going to stimulate or increase your alveolar ventilation rate. Okay, so exercise and breathing. So when we exercise, we know that we're going to breathe faster. But what we find is that because we breathe faster, and we breathe faster, we take in more oxygen. More oxygen gets delivered to the cells. The cells use more oxygen for their cellular processes. The oxygen produces more carbon dioxide, and we breathe out more carbon dioxide. But even though our respiratory rate increases, our blood levels of oxygen carbon dioxide really don't significantly change because we have adjusted our respiratory rate to accommodate the increased need for oxygen and the increased production of carbon dioxide. So we're breathing fast enough to deliver more oxygen to the tissues, and we're breathing fast enough to exhale the additional production of carbon dioxide, so we don't see big fluctuations in our oxygen and carbon dioxide levels in our blood. Now, if we exercised and did strenuous exercise but didn't increase our respiratory rate, then we would see a decrease in our blood levels of oxygen because we wouldn't be bringing in more oxygen. And we would see our partial pressure of carbon dioxide increase because we wouldn't be blowing off as much carbon dioxide as we normally would, or as we should be doing. So with exercise, if we didn't adjust our breathing, our oxygen levels would go down and our carbon dioxide levels would go up. All right. All right, so at the alveolar level, we know that this is where gas exchange happens. We know that there's actually pores in the alveoli that allow air to pass from one alveoli to the other, alveolus to the other, so that in case one alveolus is broken for some reason, not broken, but unable to participate in gas exchange, that air can pass from one alveolus to the other. And that we have these macrophages that can come in and kind of clean up any alveoli that are damaged. Or that if we breathe in particles that make it down to the alveolar level, those macrophages can come in and remove any of those foreign particles. All right, so I said earlier that we have different types of cells. Most of the alveolar walls have type 1 cells, and type 1 cells are basically just simple squamous epithelial cells. And that's for gas exchange purposes. We want the gas exchange to happen over one layer of thin, flat cells to make it easier for the body and the gases to allow for gas exchange. But part of the alveolar wall consists of these type 2 cells, which secrete surfactant. Remember, surfactant is produced by the alveolar walls to help keep the lungs or the alveoli inflated so that the lungs don't collapse. And so in total, that respiratory membrane consists of these 2 layers of cells and their basement membranes. And the gas exchange occurs through this respiratory membrane, which consists of the alveolar wall, which is a simple squamous epithelium, and then the blood capillary wall, which is a simple squamous epithelial layer, and then that basement membrane, which is like a fused membrane between these epithelial layers that join the walls of the alveoli and capillaries. And you can see that in this picture here. So here are the like simple squamous type 1 cells. The simple squamous epithelium. Here you can see the type 2 cells, the surfactant. There's like a macrophage, the alveolar macrophages. But here you can see how that we have, the simple squamous epithelium of the alveoli, the simple squamous epithelium of the capillary, and then that basement membrane. So diffusion is going to happen over kind of 3 layers. 2 layers of simple squamous epithelium plus that layer of basement membrane. Here you can just see the capillary between the alveoli. So here is an alveolar space, here's an alveolar space, and you can see the capillary between the alveoli. All right, diffusion through the respiratory membrane. The cell membranes are permeable to gases. We know that. We know at least to carbon dioxide and to oxygen. We know that respiratory membranes are permeable to, or cell membranes are permeable to anesthetic gases, because we know that anesthesia gases, you breathe those in when you go under for surgery. And we know typically molecules are going to go from regions of higher concentration to regions of lower concentration. That's simple diffusion. And that, and we know that it goes down the concentration gradient. But when we talk about respiration, we don't talk about that concentration gradient. Even though it is a concentrated gradient, now we're talking about the partial pressure gradient. So, I told you that we use the terms synonymously, but technically we have to say partial pressure gradient instead of concentration. So now gases are going to move from an area of higher partial pressure to an area of lower partial pressure. So, and we saw that the respiratory membrane is very thin. It has those simple squamous epithelial layers, and gas exchange across it is very rapid. And several factors affect diffusion across that membrane. If you have a increased surface area, shorter distances, greater gas solubility, and a steeper partial pressure gradient, that's going to allow for a better gas exchange. A lot of these factors are the same as what we learned back in chapter 2 or whatever it was, factors that affect diffusion. And then decreased diffusion occurs due to decreased surface area, like an emphysema or harm to a respiratory membrane. And the driving force for diffusion in carbon dioxide is the difference in partial pressures of the gases between the alveolus and the capillary. And we see that the partial pressure differences is actually very great. From the, when we breathe in oxygen and we breathe out carbon dioxide, there's not much carbon dioxide that we breathe in. So our cells produce a lot of carbon dioxide. So there's going to be a lot of carbon dioxide in the capillaries that's going to diffuse from the capillaries into the alveoli. And there's not a lot of oxygen in the capillaries. So a lot of oxygen is going to diffuse very quickly from the alveoli into the capillary beds. Here you can see the partial pressure differences. So for carbon dioxide, when blood enters, from the right ventricle, so we're coming from the right ventricle to the pulmonary artery to the lungs. Here we can see that the partial pressure of carbon dioxide is 45 millimeters of mercury in the blood vessel, whereas in the alveolus it is 40 milligrams of mercury. So the partial pressure is greater in the capillary than in the alveolus, so therefore carbon dioxide is going to go from the capillary to the alveolus. On the flip side, oxygen has a very high partial pressure of 104 in the alveolus compared with the capillary of 40 milligrams of mercury. So oxygen is going to diffuse from the alveolus into the capillary. Conceptually, we've known that. We've known that carbon dioxide goes from the capillary to the alveolus and the oxygen goes from the alveolus to the capillary, but we've never put numbers to this. And now we're putting numbers. So you can see that there's a big partial pressure difference in oxygen from the alveolus to the capillary, but there's not that big of a difference in carbon dioxide from the capillary to the alveolus. So the exchange rate in oxygen is going to be much faster than it is going to be for carbon dioxide because there's a bigger difference. There's a bigger partial pressure difference in oxygen compared with carbon dioxide. Oxygen, there's a 64 millimeter mercury difference. 104 minus 40 is 64, whereas with carbon dioxide, 45 minus 40 is only 5. But because there's still a difference, carbon dioxide will still go across from the capillary to the alveolus, but it's not going to be as quick as oxygen. And then as blood flows from the pulmonary artery through the capillary onto the other side, we can see that the partial pressure of carbon dioxide and the partial pressure of oxygen are the same, meaning that we are at equilibrium. So no more diffusion of carbon dioxide, no more diffusion of oxygen is taking place. And then this blood will go to the pulmonary vein through back to the left atrium of the heart. All right, high altitude. So even though, air is air, so we still have 21% oxygen. The PO2 is going to decrease because that atmospheric pressure is lower. We started out with 760 millimeters of mercury at sea level. All right, so when you go higher up, so we have the 760 millimeters of mercury at sea level, and as you start to climb, mountains or something like that. So if you go to, Machu Picchu, the atmospheric pressure there is 560 millimeters of mercury. So, so even though we're still 21%, the partial pressure of oxygen is only 1117.6. If we went to Pike's Peak, Pike's Peak is 480. So your partial pressure of oxygen is only 100.8 at Pike's Peak. And, let's say you decided to climb Mount Everest. So the partial pressure, or the pressure at the Mount Everest summit is 250. Even though air still is 21%, the partial pressure of oxygen at the top of Mount Everest is only 53.13. So, as you go up higher in elevation, even though the air is still 21%, the atmospheric pressure is lower. And so therefore, oxygen is going to diffuse more slowly into the blood. Your hemoglobin saturation is going to decline. And that's when you're going to experience altitude sickness, or we have this thing called high altitude pulmonary edema would be the most severe form of it. But I'm just Googling altitude sickness. So, with altitude sickness, you can have like headache, nausea, shortness of breath, vomiting, insomnia, dizziness, lethargy, appetite loss, inability to exercise, reduced coordination, and performance. So your body is going to try and overcome these signs and symptoms to obtain more oxygen. So it's going to increase your heart rate. It's going to increase your respiratory rate. Because of that lack of oxygen, it's going to stimulate your bone marrow. It's going to release that erythropoietin to stimulate your red blood cell production. It's going to try and make more hemoglobin. And that's why athletes like to abuse erythropoietin. And a lot of times athletes will go train at higher altitude places before competing to go ahead and get used to the higher altitude, to go ahead and get those red blood cells and the increased hemoglobin production, and then they go compete at the lower altitude levels to get a little bit of competitive advantage. And then in worst case scenarios, you could have this high altitude pulmonary edema, which, you'll still have the headache, nausea, vomiting, rapid heart rate. But with that pulmonary edema, you'll have fluid on your lungs, cyanosis, that hypoxia is going to constrict your pulmonary blood vessels. Your capillary pressure is going to rise. You're going to have filtration problems. Okay. Oh, I will say, I went to Machu Picchu one time, and I didn't have any effects of high altitude or high altitude sickness, but the person I was with did. And they have oxygen tanks all over the place that you can have oxygen. And they gave you this tea that they call it cocoa tea or coca tea. I'm like, oh, here, drink this. It'll make you feel better. And so I drank it. I had a couple cups of tea. Come to find out, it was like tea with cocaine in it. It was a cocaine derivative tea. I'm like, oh my gosh, I can't believe I drank cocaine. Anyway. All right, so disorders that impair gas exchange. So these are more perfusion disorders, not ventilation, perfusion. So impairs gas exchange. Pneumonia. pneumonia is just an infection in the lungs. So the alveoli are going to swell because they're edematous. Where you have fluids and white blood cells, or they're going to enter the alveoli. They're going to become abnormally permeable, and it's going to decrease the surface area for gas exchange. Tuberculosis is where you have these tubercle things, and it's just basically dense connective tissue that form around these infected areas of the lungs to wall off the infection. And they kind of look like little spots on the lungs to help stop the spread of infections. And that lung tissue is pretty much destroyed then, and that reduces the surface area for gas exchange. Atelectasis. Atelectasis is just basically a lung collapse or region of a lung collapse. I don't like the term lung or region of a lung collapse. Atelectasis usually is just a region or a small portion of a lung collapse. Usually when you say lung collapse, that's going to be more pneumothorax as opposed to atelectasis. Atelectasis is more of a small region of a lung being collapsed. Sometimes you'll experience symptoms with atelectasis. Sometimes you won't. Typically, you don't need a chest tube with atelectasis. With pneumothorax, you will need a chest tube to open up that. Usually, with pneumothorax, the whole lung is collapsed. You need the chest tube to open up that lung. With atelectasis, usually those functional regions will be strong enough to carry on the gas exchange to compensate for the obstructed areas. ARDS, acute respiratory distress syndrome. It's a form of atelectasis. That's where the alveoli collapse. Usually a surfactant issue. Another one that's not on here, adult sleep apnea. It's usually an obstruction of the upper airways. That's going to be more of a ventilation issue, not a perfusion issue. I guess I should have put that one on the ventilation side, not the perfusion side. All right, so how do gases actually get transported between the lungs and the body cells? So specifically carbon dioxide and oxygen. So either they're going to be dissolved in the blood plasma or they're going to be combined chemically with other substances. So with oxygen, remember that we had those partial pressure differences that cause oxygen to diffuse from the alveoli or the alveolus into the blood. And then we now have the red blood that is 100% saturated in the pulmonary veins that go back to the left side of the heart. At that point, oxygen is bound to, oxygen can be transported through the blood bound to hemoglobin. And hemoglobin, or globin, is actually the protein part of hemoglobin. All right, so 98% of the oxygen is bound to hemoglobin in the red blood cells. And like I said, globin is part of the is the protein part of hemoglobin. And if we look at the structure of hemoglobin, there's actually 4 parts to hemoglobin, and it's actually 4 polypeptide chains that make up hemoglobin, and one hemoglobin can bind up to, or can contain, 4 different oxygen molecules. And there's those chemical bonds that formed between oxygen and hemoglobin are relatively unstable, which is good because we want that oxygen to eventually go into the cells and not stay bound to hemoglobin. All right, and the rest is going to be bound to, or going to be, the other 2% is going to be dissolved in plasma. Okay, so, and then we know that oxygen is released from that hemoglobin and moves from the blood into the tissues. And we have those partial I can never say this word. We have the differences in that partial pressure of oxygen that causes the oxygen to move from the hemoglobin or from the blood to the cells. So remember that gases move not because of their concentration, but because of their partial pressure differences. So in the alveoli, the partial pressure of oxygen is greater than in the alveoli than it is in the capillaries. So oxygen is going to move from the alveoli to the capillaries. And now we get to the cellular level, and the partial pressure of oxygen is greater than the capillaries than it is in the cell. So oxygen is going to move from the capillary into the cell. And after we drop off the oxygen to the tissues or the cells, it says that hemoglobin is still about 75% saturated in the venous blood. And we'll come back to that statement here shortly, and we'll make that statement more sense, make more sense. But we actually don't dump off all of the oxygen off of the hemoglobin. And it says oxygen poor blood. So that's how we donate or designate, the red blood vessel versus the blue blood vessel. So once we dump off the oxygen, it's not a red blood vessel anymore. It's a blue blood vessel, to designate that it's an oxygen poor blood. It's not fully oxygenated. And so, and it's also to ensure that the respiratory system can adjust those carbon dioxide levels and pH as necessary. So, just going back to that statement, the oxygen, after dropping off the oxygen to the tissues or the cells, hemoglobin is still about 75% saturated in venous blood. So if you think about, for those of you who've been around for a while and have been doing CPR for a long time, we used to do, for CPR, airway, breathing, circulation. You do CPR, you give some breaths. You do some CPR, you give some breaths. And now we're not focused too much on that whole breathing mechanism. We're focused more on chest compressions. And that's because of this whole oxygen or hemoglobin is still 75% saturated in venous blood. Because we know that we can, the focus should be chest compressions, because that blood can circulate several times and still have oxygen still attached to that hemoglobin. And we'll see that in this next slide. So this is what's called a hemoglobin saturation curve. Some people call it an oxygen hemoglobin dissociation curve, an oxyhemoglobin dissociation curve. It has multiple names to it, but basically it is a comparison of your PO2 versus your percent saturation of hemoglobin. So this is what your, when you put your pulse ox on your finger at the doctor's office or your respective healthcare provider, this is the number that you're going to read, you're going to get. And chances are, you want 98, 99, 97% as your pulse ox. And, we talked about, and don't quote me on that. And you can, well, I guess first you can see, we'll just choose this value right here. If we're 100% saturated, that number corresponds to 100 PO2. That actually isn't necessarily accurate. That might be 99.9%. This value might be 99.95%. This value 99.99%. This value's 99.999%. Don't quote me, but I think that when we get to truly 100% saturated, this graph can go on for years, not years, but this graph goes on for a while. And I think in order to get a true 100% saturated, I think if I remember correctly, I think your PO2 has to be 663 in order to truly be 100% saturated. Again, don't quote me on that. That's just something that's pulling cobwebs out of the back of my mind, and I could be making it up, but I think that's the magic number. But, we can see that pretty much if your PO2 is 100, you're essentially, 100% saturated. So if I'm, measuring, 99% on my O2 saturations at the doctor's office, I'm going to be at about, almost 100 for my PO2. Now, if we go back to this previous statement, hemoglobin is still about 75% saturated in venous blood. So if I'm going to go to 75% saturated, I'm going to go to about right here. 75% saturated, my PO2 is still about 40. So I still have a lot of oxygen that I can give, which is why we're still focused on chest compressions and not the whole breathing. I'm going to pause the video a second because there's a statement that I wanted to come back to, but I can't remember what that statement was. I do remember one of the things that I wanted to say is, remember how we talked about atmospheric pressure being 760 and the oxygen content being 21%. And then that we did that calculation and that our partial pressure of oxygen was 160. So if we looked at our partial pressure of 160, obviously that falls outside of that chart. So we'd be, somewhere, up around here. If that's 140, that'd be 150, and then there's 160. So we're still looking, we could theoretically get our percent saturation of hemoglobin at around, 100%. So theoretically, we could be around 100% saturated even with 21% oxygen. Okay, I remember the statement that I wanted to talk about. So when we were talking about peripheral chemoreceptors, there was a statement that I made. It says that, let me just go back to it. Okay. Peripheral chemoreceptors. It usually does not cause a major response until the PO2 decreases to about 50% of the normal value. And I said that we'd come back to that statement a little bit later. And I said that, that yes, our PO2 does, or our partial pressure of oxygen does affect our rate of breathing, but it's going to be more our CO2 levels that are going to be our drive to breathe. But the PO2 does affect it as well, but it usually doesn't cause a major response until the PO2 decreases to about 50% of our normal value. So I'm going to go look at this graph. And if we look at our PO2 of dropping to about 50% of our PO2 of 50%. So if our 50%, let's say that at atmospheric pressure, our PO2 is 160, and let's say that, our normal oxygen saturations, let's see, how do I describe this? So let's say that our okay, I know how to do it. Okay, so looking at this graph, it says that our PO2 has to drop about 50%. So here our PO2, let's just use this graph. Our PO2 here ends at 140. So 50% of 140 would be 70. So 70, if we look at it, 70 would be an oxygen saturation of about 95%. Typically, you don't see oxygen saturations of 95%. Typically, you're going to see them at around 97 or 95 or 97, 98, 99%. Can you see them? Absolutely. You're going to see oxygen saturations of 92, 93%. Especially, with smokers or people who are obese or people with sedentary lifestyles, they're going to have lower oxygen saturation. You might even see, with emphysema and some respiratory conditions, you're going to see oxygen saturations in the 80s. But in your healthy people, you're going to see oxygen saturations in the high 90s. So that's why I said usually doesn't cause a major response until PO2 decreases to about 50% of its normal value. So rarely are you going to see, or not rarely, I guess I shouldn't say rarely, but a lot of times you're not going to see your peripheral chemoreceptors kick in because your central chemoreceptors are probably going to kick in before your peripheral chemoreceptors are going to kick in. And there's more physiology behind that statement, which I'm not going to get into. All right. So we kind of looked a little bit at this with our PO2 and our PCO2 levels in the alveoli, alveolus, and the capillary. We saw that our alveolar PO2 level was 104. So right as our capillaries leave the lungs, our PO2 levels are going to be 104. And then they go to the left side of the heart, and then they go to the systemic circulation. So right as the blood leaves the heart and starts dropping off oxygen, we're going to see the PO2 drop a little bit to 95 millimeters of mercury. And then eventually, once we get to the tissue level, the PO2, once the blood gets to the tissue level and starts dropping off. Okay, let me start over. So the partial pressure of oxygen in the alveolus is 104 millimeters of mercury. And then oxygen is going to diffuse into the alveolar capillary. And then in that blood, the partial pressure of oxygen is now 104 millimeters of mercury. And then we know that oxygen binds with hemoglobin, 98% of it, and the 2% gets dissolved in plasma. So, and then as the blood leaves the heart, the partial pressure of the systemic arteries is going to become 95%. And that's because the oxygen is starting to get dumped off as soon as the blood leaves the heart. So you can see that the PO2 starts to decrease as soon as the blood leaves the heart. And then that oxygen-rich blood passes through the left side of the heart, systemic capillaries. Oxygen is going to diffuse into the tissue cells. And at that point, the partial pressure of venous blood after oxygen is dumped off at this tissue cellular level is going to be 40 millimeters of mercury. And then the oxygen is going to come back to the right side of the heart. And at the right side of the heart, the blood's going to be partial pressure of oxygen as 40 millimeters of mercury. Going to go to the right side of the heart and then through the pulmonary artery system and then back to the alveoli and drop off carbon dioxide and pick up oxygen. All right, so factors that decrease or that increase the release of oxygen from hemoglobin. So we can look at, and basically, we can look at two factors that are going to be simple diffusion. One is your PO2 levels. All right, so a decrease in PO2. This is just simple diffusion. So remember concentration gradient, an area of higher concentration, an area of lower concentration. So oxygen goes from an area of higher partial pressure of oxygen to an area of lower partial pressure of oxygen. We see that in the alveolus to the capillary and the capillary to the tissue level. An increase in your partial pressure of carbon dioxide. This also follows simple diffusion. And this is just basically a reverse way of saying the above statement. The above statement being, oxygen goes from an area of higher partial pressure to an area of lower partial pressure. Oxygen goes from an area of lower partial pressure of CO2 to an area of higher partial pressure of CO2. So if we're looking at, that's my alveolus and that is my capillary. We know we have a lot of oxygen here. And we have very little carbon dioxide in the alveoli. And we know in the capillary, we have a lot of carbon dioxide and we have very little oxygen. So in that first statement, we would just say oxygen goes from an area of higher partial pressure of oxygen to an area of lower partial pressure of oxygen. So oxygen is going from the alveolus to the capillary. And then it also says an increase in PCO2. And again, simple diffusion. So oxygen goes from an area of lower partial pressure of carbon dioxide to an area of higher partial pressure of carbon dioxide. So this is just, again, oxygen is going from an area of low partial pressure carbon dioxide to an area of higher pressure of carbon dioxide. Oxygen is trying to dilute that carbon dioxide in the capillary bed. Or we could do the same analogy at the cellular level. Oxygen's going from the capillary to the cell because the cell has a higher concentration of carbon dioxide. Increase in acidity. Remember that CO2 levels and your hydrogens, they're going to go in the same direction. Increase CO2, increase in hydrogen leads to a decrease in pH. So as your concentration of hydrogen ions increases, which means you're increasing acidity, we can do increase in acidity, lowering, so your pH decreases. The amount of oxygen released from hemoglobin increases. So this is just kind of like another way. So this statement is just another kind of rephrasing of this statement, but putting it more in terms of hydrogen ion concentration as opposed to carbon dioxide. Because remember, carbon dioxide and hydrogen ion concentration fall hand in hand. So as your blood pH decreases, your hydrogen ion concentration will increase, and the amount of oxygen is going to increase, or the amount of oxygen that's released from oxyhemoglobin increases. And also we have an increase in temperature. So as your temperature increases, the amount of oxygen that gets released from oxyhemoglobin increases. So now, I've introduced this term oxyhemoglobin. So we have hemoglobin, and then we rename hemoglobin depending on what's attached to it. So hemoglobin has nothing attached to it. If oxygen's attached to it, we say it's oxyhemoglobin. If carbon monoxide is attached to it, we say it's carboxyhemoglobin. If carbon dioxide is attached to it, we say it's can't say it. I'll try it again. Carbaminohemoglobin. We'll see that in a couple slides. Carbaminohemoglobin. That is when carbon dioxide is attached to hemoglobin. All right, so how do we remember all of this? We can see that, and we have this curve that we looked at, and this is our normal oxyhemoglobin dissociation curve. Oxyhemoglobin, oxygen is now attached to hemoglobin, and this curve can shift to the right or to the left depending on what happens or what's happening in the body. And I use this acronym RIGHT to help me remember. And I say, rise in 2,3-DPG, hydrogen ion concentration, and temperature. That will shift the curve to the right. Now, 2,3-DPG, we haven't talked about, we're not going to talk about. If you really want to know, 2,3-DPG, it stabilizes the deoxygenated form of hemoglobin. It's beneficial to oxygen unloading in muscles during exercise, and that's really all I'm going to say about 2,3-DPG. But hydrogen ion concentration. So anytime our carbon dioxide goes up, anytime our hydrogen ion concentration goes up, if it says your pH goes down, that's what we're talking about. And then temperature. If you increase your temperature, all of these things will shift your curve to the right. So it'll cause the O2 dissociation curve shifting to the right. So what that means is, so here, this one we'll look at here, pH of 7.4. Remember, our pH of blood is 7.35 to 7.45. So 7.4 is going to be the neutral one, and this is our normal curve. So a rise in your hydrogen ion concentration. So that means we have a lowered pH because we have an increase in our hydrogen ion concentration, or we have an increase in our CO2 level, or we have a decrease in our pH. So here we could say decrease in pH, increase in our hydrogen ion concentration, or we could have an increase in our PCO2 levels. And actually over here is where we'll look at our CO2 levels. So that will all shift the curve to the right. And you can see that our pH went from 7.4 down to 7.2, which is going to shift that curve to the right. Here you can see the pH increased to 7.6, which is going to shift that curve to the left. Looking at the PCO2 in that left-hand curve, here, if you don't know, our normal CO2 is 35 to 45. So an increase in your PCO2 will shift the curve to the right, and a decrease in your CO2 levels will shift the curve to the left. Now, what does that mean? If you shift the curve to the right, it's going to lower your hemoglobin's affinity for oxygen. So that means that hemoglobin will release oxygen to the tissues more easily. And a left-hand shift will increase the hemoglobin's affinity for oxygen, meaning that hemoglobin will hold on to oxygen more. We didn't talk about temperature. When we convert, 98.6 to Celsius, 98.6 translates into 37 degrees Celsius. So 37 degrees Celsius is our normal curve. Rise in temperature. So if we increase our temperature, we're going to shift the curve to the right. If we lower our temperature, we're going to shift the curve to the left. All right. Now, carbon dioxide. How does carbon dioxide get transported? Remember that cellular metabolism or cellular respiration. Respiration generates carbon dioxide, water, and ATP, and that carbon dioxide gets diffused from the tissues or cells into the bloodstream because of that partial pressure difference between that tissue and the capillaries. Carbon dioxide is transported back to the lungs in one of three ways. The first way is it can be dissolved in plasma. About 7% of carbon dioxide is dissolved in plasma. Remember, both oxygen is 2% dissolved in plasma. Carbon dioxide is 7% dissolved in plasma. Carbon dioxide and oxygen are both water soluble, so it can be dissolved in the plasma. And in this case, it remains as carbon dioxide. Carbon dioxide can also bind to hemoglobin that's present in red blood cells, and now we call that carbaminohemoglobin. Remember, oxyhemoglobin, carboxyhemoglobin is carbon monoxide. Carbaminohemoglobin is when carbon dioxide binds to hemoglobin. That's 23% of how carbon dioxide gets from the tissue cellular level back to the lungs to get exhaled. And 70%, so the majority of how carbon dioxide gets back to the lungs is transported as a bicarbonate ion. And I guess I don't need the majority is transported that way. You can figure that one out. So bicarbonate, it forms as this reaction. Between carbon dioxide and water. And it says carbonic anhydrase is the catalyst or enzyme that does this. And if you remember way back in chapter whatever, when we talked about, chapter 2 or 3 or something like that, when we talked about enzymes and catalysts, I said that carbonic anhydrase was the fastest enzyme out there. It speeds up this reaction 10 to the 4th or 10 to the 5th time. So about 1,000,000 times, 10,000 to 1,000,000 times faster than it would occur without the enzyme or naturally. So basically we have carbon dioxide and water is going to form this carbonic acid, which can readily dissociate into hydrogen ions and bicarb, or this anion, and it gets transported back into the blood. It gets transported in the bloodstream like that, and once it gets back to the lungs, it's going to get converted back to carbon dioxide, and that's how we breathe out. Once it gets converted back to carbon dioxide, we'll breathe out that carbon dioxide. So upon reaching the lungs, bicarbonate ions, this HCO3 is able to diffuse back into the red blood cells, and this reaction will go in the opposite direction to produce carbon dioxide and water, and carbon dioxide will then go from the bloodstream into the alveoli, and then it will, then we exhale it through our lungs. So now I just want to talk about like the pH of your blood. So all right, so let's talk about what has an effect on the pH of your blood. Do you think that nitrogen has an effect on the pH of your blood? No, it does not. Nitrogen has nothing to do with the pH of your blood. First, we haven't talked about nitrogen at all in this lecture, so no. Oxygen, does oxygen have anything to do with the pH of your blood? No, it does not. What about carbon dioxide? Does carbon dioxide have anything to do with the pH of your blood? Yes, it does. One, remember I said that anytime we talk about carbon dioxide and hydrogen ions, they go hand in hand in altering the pH of your blood. Increase in carbon dioxide, increase in hydrogen ions lead to a decrease in your pH. Decrease in carbon dioxide, decrease in hydrogen ions, increase in pH. So yes, carbon dioxide will have an effect on the pH of your blood. And we see that in the equation. Carbon dioxide goes to carbonic acid, which gets dissociated into hydrogen ions. Hydrogen ions is a direct measure of the pH of your blood. So that goes to the next question. Do hydrogen ions have an effect on the pH of your blood? Well, of course it does. I mean, you should say, well, you idiot, of course it does. All right. So another critical thinking question. Um, you hear the whole, the little kid gets really mad and upset and says, well, I'm going to hold my breath until I die. Okay, well, can this really happen? Can someone die because they hold their breath? Um, what do you think? So I'll just ask you some questions. So when you hold your breath, what's going to happen to your carbon dioxide levels? Your carbon dioxide levels are going to increase. Your body is still producing carbon dioxide, but you're not blowing off that carbon dioxide. What will happen to your hydrogen ion concentration? Your hydrogen ion concentration is going to increase because remember, increase in carbon dioxide, you're holding your breath, leads to an increase in hydrogen ion concentration. So what will happen to the pH? Well, it's going to decrease. Increase carbon dioxide, you're holding your breath. Increase in hydrogen ion concentration, decrease in pH. What about your oxygen levels? Well, your oxygen levels potentially will decrease depending on a bunch of factors, but depending on how much oxygen reserves you have, depending on how much oxygen is already bound to hemoglobin, are there any perfusion issues? Do you have any defects in your hemoglobin? But let's say that, so let's say that you do have a decrease in your oxygen levels. If you do have a decrease, you're probably not going to have that much of a decrease in your PO2 or in your oxygen saturations. You're definitely not going to have that much of a decrease as much as your carbon dioxide will increase. So your carbon dioxide will be more of an adjustment than your oxygen will. And again, this goes back to the new CPR algorithm where we're going to be focused more on the chest compression as opposed to the breathing. So what is the result of all this? You have someone who is holding their breath, who is thinking she's going to hold her breath until she dies, but she holds her breath and the carbon dioxide levels are building up in her body. She might pass out, but once she does pass out, she's going to immediately breathe anyway, because her body's going to kick in and start breathing the second she passes out anyway. Or her carbon dioxide levels are going to get high enough to stimulate those central chemoreceptors to trigger an inspiration. So if you say, I'm going to hold my breath until I die, okay, go for it. Have your temper tantrum, because it's not going to be you can't hold your breath until you die. All right. So the next question that I want to ask is, why are the concentrations of carbon dioxide, or I guess I should not use the term concentration, why are the partial pressures of carbon dioxide and hydrogen more important to the respiratory control than the partial pressure of oxygen? Why are the partial pressures of carbon dioxide and hydrogen or I guess I should say, why is the partial pressure of carbon dioxide and the concentration of hydrogen more important to the respiratory control than the partial pressure of oxygen? So we kind of answered this question in the last question about holding your breath until you die. The oxygen levels will remain high enough in the blood even after oxygen is delivered to the tissues. So during normal functioning, oxygen levels typically don't drop low enough to put cells in danger. Again, think of the new CPR algorithm. All right, now we're going to look a little bit at hyperventilation. You know, hyperventilation where you breathe too fast. What will happen to your carbon dioxide levels with hyperventilation? They are going to decrease. With hyperventilation, you are blowing off more carbon dioxide faster than your cells or faster than your body produces it. What about your oxygen levels? So that's actually a good question. So some studies say that your oxygen levels will remain the same, and some studies say that your oxygen levels will decrease. And some studies say that your oxygen levels will increase. So who knows? What will happen to your hydrogen ion concentration? So again, go back to what goes on with your carbon dioxide levels. With hyperventilation, your carbon dioxide levels are going to decrease. Therefore, your hydrogen ion levels will decrease. Again, hyperventilation eliminates carbon dioxide faster than it is being produced. So what effect does hyperventilation have on your pH? So carbon dioxide levels go down, hydrogen ion concentration goes down, your pH will increase. All right, this is just a kind of picture version of how carbon dioxide is transported in the blood. Basically down here is where you can see the equation of, the bicarb and the carbonic acid. Here, there's the chloride in there. There's this thing called chloride shift. We're actually not going to cover that in this class. But just know that there is this thing called chloride shift. I'm not even going to go in further detail on that. All right, so gases entering the bloodstream. Summary slide, oxygen, about 2% dissolved in plasma. I'm just going to kind of delete this to keep the numbers the same as what we had on previous slide. 7, 23, 70, there we go. Okay, so we're going to talk about, since we're talking about gases in the blood, we're going to also talking about breathalyzers and alcohol. So how do you think alcohol gets from, the stomach to your mouth to blow into a breathalyzer? So from the stomach, alcohol gets absorbed, because remember the stomach absorbs some water and some alcohol. The water or the stomach does very little absorption. Absorption is more small intestine. So from the stomach, alcohol will absorb from the stomach, alcohol will get absorbed and go to the liver for metabolism. And then the alcohol will go into into your systemic bloodstream. The alcohol molecules will diffuse from the bloodstream into the alveoli through the respiratory membrane. And, this happens by simple diffusion, just like oxygen and carbon dioxide does. Diffusion. All right. And so this allows the breathalyzer to detect the alcohol on a person's breath. All right, we talked a little bit about carbon monoxide, and the only thing that I've really mentioned so far is that we have carboxyhemoglobin when carbon monoxide attaches to hemoglobin. So, with carbon monoxide poisoning, I guess first, what produces carbon monoxide? Carbon monoxide is any incomplete burning of material containing carbon. So this could be any products that use gas, natural gas, oil, kerosene, propane, charcoal, or wood as their fuel source. If you're looking at stuff inside the house, that could be gas powered water heaters, stoves, furnaces. They can all produce minute amounts of carbon monoxide, but the main culprit of carbon monoxide poisoning is kerosene heaters. And oftentimes people use kerosene heaters inside their houses or homes in the wintertime to keep warm because it's cheaper than paying for heat. And without a way for carbon monoxide to escape, it will continue to build up inside the house. Carbon monoxide is odorless, tasteless, and colorless. And if you have carbon monoxide poisoning, you can have headaches and weakness, dizziness, confusion, nausea, vomiting, blurred vision, shortness of breath, etc. But some people will turn on the kerosene heaters and fall asleep before they start to experience any signs and symptoms of carbon monoxide overdose or poisoning. And once you fall asleep, it's very dangerous. And what happens inside the body when there's carbon monoxide is that this carbon monoxide attaches to the hemoglobin, the same hemoglobin that oxygen would bind to, and it's a competitive binding. So basically, carbon monoxide is going to win out over oxygen. And it's going to bind to the same sites on hemoglobin so that oxygen can't bind. So that means that the oxygen carrying ability of the blood is reduced. All right, just some lifespan changes. Those ciliated epithelial cells become fewer in number. Cilia become less active gradually over time, but with smoking, it's going to be exaggerated because not only do you have the natural progression of cilia becoming less active, but you have smoking on top of that, and the cilia are going to become non-functional or dysfunctional as well. Your mucus is going to become thick as you get older. Your swallowing, gagging, coughing reflexes are going to become slower and not as strong. Macrophages are going to lose their efficiency. It's going to be hard to cough up some of that gunk. You're going to be more prone to respiratory infections. Your alveolar walls are going to thin, your alveoli are going to merge so that that surface area is going to decrease. So your perfusion area is going to decrease as well. So you might have some perfusion issues. All right, and that is it for chapter 19. And if you have any questions, please let me know. All right, take care.